Good morning and welcome to everybody. Everybody present here today, and there's a huge number of people attending, reflecting the great interest in the subject and the importance of the issues to be discussed. I particularly want to welcome Professor Joseph Ibrahim from Monash University in Australia and all those who are joining us today from Australia. I appreciate that it's evening time there, and as I say, we have a huge number of people who've registered for today's event from as far away as Australia, but more widely than or more nearer to us in Europe as well as across Ireland. I'm Vivian Gearan. I'm chair of the Irish Association of Social Workers, and I'm also chairing the first part of this webinar, Behind Closed Doors, Abuse in Care Settings. The issues about which we will hear and discuss today are of great importance to the Irish Association of Social Workers, as they are, I'm aware, to BASW in Northern Ireland as well. And they're also of great importance to all of you and to all our colleague professionals and indeed wider society. This webinar is of course being held on World Elder Abuse Awareness Day, today, the 15th of June. And although we are marking World Elder Abuse Awareness Day in this way, all the organisers of today's events are keen to take this opportunity to broaden our focus to include consideration of the care and indeed abuse of people of all ages in care settings. And indeed, this is reflected in our range of excellent speakers today. Given that you've already signed up and no doubt have seen it on the background information, you will be aware of the running order. Just an overview, we will have a total of 6 presentations divided into 2 sessions, each with 3 presentations, followed by a Q&A after each of those sets of 3 presentations. So I'm chairing this first session. My colleague Michelle McMaster, Professional Officer with BASW Northern Ireland, will chair the second half of the webinar, including making the closing remarks. And while the event, as I said, is truly international, it is great, I believe, that social work in Ireland, North and South, is collaborating so strongly together, again, in this way today. We have an absolutely fantastic lineup of speakers who will be introduced individually before their respective presentations. And I'm sure I speak for all of us when I say I'm really looking forward to all of the presentations. I also want to thank in advance all our contributors for giving of their invaluable time and expertise and being with us today. So just before our first presentation, I want to make a couple of points. First of all, regarding language, I'm a firm believer in the saying that words create worlds. And in that context, I want to suggest that we all be conscious of the language and terminology that we use, not just today, but more generally. The IASW, for example, in the context of listening to what those directly affected are telling us, prefer to use the term older people rather than the elderly or senior citizens, for example. We also try to avoid referring to older people as vulnerable persons, as it is not age per se that makes one vulnerable, but rather the risks that one faces or the hazards in one's environment. I am conscious that problematic issues with such terminology have been brought into specific focus over the past 18 months or so in the context of the ongoing pandemic. Just a couple of practical items then as well, just to remind people to stay muted. And also, if you have any questions, and I would encourage that if you have a question as we go along, to please, as the opening slide said, put those questions into the Q&A function button on your screen. On a different practical matter, for all of you who use social media, and particularly Twitter, for example, do feel free, as we also said on the opening slide, to tweet about today's event. And we had suggested hashtags that you might use, specifically hashtag WEAAD and hashtag residents have rights, as well as hashtag SW responds and hashtag no excuse for elder abuse. So finally, without further ado, I want to now introduce our first presentation, which will be by Dr. Sarah Donnelly of the School of Social Policy, Social Work and Social Justice in UCD, and Susan Gaynor of Care Champions. Sarah, first of all, is an assistant professor of social work in the School of Social Policy, Social Work and Social Justice at UCD, and co-convener of the European Network for Gerontological Social Work. Prior to moving to academia in 2014, Sarah worked as a senior medical social worker for 15 years in Tallaght University Hospital, specializing in age-related healthcare. Sarah's research interests include aging and dementia, adult safeguarding, home care robotics, capacity and decision-making. She is a Geary Fellow and member of the UCD Centre for Interdisciplinary Research, Education and Innovation in Health Systems, and an active member of the Irish Association of Social Workers. Susan Gaynor is a Montessori teacher and mother from Dublin. She feels very strongly about the lack of regulations to ensure our care home residents are protected from neglect and abuse. In Susan's own profession, by contrast, there is a very high standard of regulation in place to ensure that children are well looked after, and it ought to be similar in our care homes. So, Sarah and Susan, you have the floor.
Thank you very much, Vivian. And I'll just try and share my screen, which of course seems to have disappeared just when you want it not to disappear. Let me just see. Okay, sorry. Not sure where it has gone to. Sorry, I'll be with you in a few moments. Apologies for the delay.
You're all right.
All right, if it can go wrong, it will go wrong. We'll try again. Yeah, okay, here we go. And okay, so good morning, everybody. And again, I'd just like to really echo Vivian's sentiments around apologies. Sorry, this has gone absolutely AWOL of me. Sorry. Sorry, so just to echo Vivian's apologies that I'm going to stop sharing again and go back to start to welcome everyone today. And, you know, we're delighted to have such a huge range of speakers from across the globe, and I'd really like to sincerely thank Susan in particular for agreeing to co-present with me this morning around some of the very important issues we're going to be discussing. Try and get back to the start again. Okay, yeah, and really today, apologies, really I would just wanted to give a very broad overview about the concept of elder abuse, and I suppose why it's so important that we mark today as World Elder Abuse Awareness Day. So what I wanted to do was just to start off with some facts around elder abuse. So elder abuse, again, there's no officially recognized definition of elder abuse, but the World Health Organization in 2002 defined it as a single or repeated act or a lack of appropriate action occurring within any relationship where there is an expectation of trust, which causes harm or distress to an older person. And again, I think it's important to focus on that issue of expectation of trust. And again, we know that this type of violence constitutes a violation of human rights of our older people and can include abuse such as physical abuse, sexual, psychological and emotional abuse, financial and material abuse, abandonment, neglect, and serious loss of dignity and respect. Elder abuse is a huge, important public health issue with serious social, economic, and health consequences. And again, we know with our aging populations that elder abuse is increasing, that it often goes unreported, and with official numbers most likely underestimating the true extent of the problem. So again, one of the difficulties we have around elder abuse, I would say, is the dearth of literature and research studies that we have, I suppose, shedding light on this issue. A 2017 study carried out by Yon et al. Based on, I suppose, available evidence from 52 studies in 28 countries, including 12 low to middle income countries, estimate that over the past year, 15.7% of people aged 65 and older were subject to some form of abuse. Again, we also know that rates of elder abuse are particularly high in institutions such as nursing homes and long-term care facilities, with 2 in 3 staff reporting that they have committed abuse in the past year, according to WHO statistics. We also know that rates of elder abuse have increased during the COVID-19 pandemic, and we also envisage that rates of elder abuse will continue to increase with our aging population. Elder abuse can lead to serious physical injuries and long-term psychological consequences. And as I said, with our aging populations, we really expect those numbers to increase. And I think when we think about elder abuse within the context of COVID-19 and everything that's happened over the last 12 to 18 months, I think this definition by Louisa Ronson, who's a geriatrician in America, is particularly striking. So she's described elder abuse as when a trusted other, so whether that's your country, the people in charge of the place where you live, your healthcare system, neglect your needs or fail to act in ways that cause you harm or distress. And again, I think it's really important that we hold that definition as we work through this morning's presentations. So what causes or contributes to elder abuse? Again, the literature suggests that often it's our policies and practices that make it hard for our older people to stay involved and connected with communities as we age. And as a result, many older people are more likely to experience social isolation, which increases the likelihood of abuse and neglect. Again, we know that elder abuse affects older people across all socioeconomic groups, cultures and races, and can occur anywhere where they're disconnected from social supports, whether that's in their own homes, in nursing homes, in assisted living or supported living facilities, in institutional settings, or indeed in hospitals. Again, I think it was important to touch on the whole concept of abuse across the life course, because we know the childhood history of abuse also has an determining influence on abuse in later life. And again, international studies strongly suggest that as gender as a risk factor for elder abuse, with women more likely to experience elder abuse than men. Again, there are racial and ethnic-based differences have been identified, with some studies suggesting that people from ethnic minorities communities are less likely to report abuse for fear of, I suppose, repercussions and also reporting poor standards of care. Again, we know that poverty is the main contributor of elder abuse in developing countries. Older people may be impacted by poverty through poor nutrition, inadequate housing, clothing, or indeed social isolation. So moving on to abuse in care settings, and I suppose what little is known about the prevalence of abuse in nursing homes or care settings derives largely from research undertaken outside of the UK, and again suggests that such abuse is a common occurrence. But again, we can see that a lot of these studies are quite dated, and I would again highlight the dearth of research we have in this area. Cooper et al. Did some nice work in 2008 and did a meta-analysis of prevalence studies in both domiciliary settings and care and nursing home settings. And they determined that overall 16% of staff admitted having committed psychological abuse, 10% admitted to physical abuse, whilst 80% reported witnessing others committing abuse in their workplace. And again, in terms of reporting abuse in nursing homes for older people is not always reported, and sometimes indeed it's deliberately concealed, with only a fraction of the abuse that occurs often being brought to the attention of safeguarding authorities such as local social service departments, or indeed inspection authorities such as HICWA or the Care and Quality Commission in the UK. A number of researchers maintain that as few as 1 in every 4 or 5 cases are reported, whereas the World Health Organization estimates it somewhat lower as 1 in every 15. But again, we know there are significant barriers to staff reporting abuse. Sometimes that's around personal consequences of reporting abuse, which could include victimization, intimidation, ostracization, reprisal from peers, managers, employers, and loss of employment. And again, we know from the existing literature as well that often toxic organizational environments can be a huge barrier to reporting within that context. I suppose moving on to the situation here in the Republic of Ireland as a case example, and I suppose our lack of legal protections for those in care settings. And again, this has been very well highlighted. So I suppose from the HSE, who oversee the Safeguarding and Protection social workers have very much highlighted in their annual report last year that social workers continue to work on the legal lacuna with no primary legislative basis for their work, and particular issues being, I suppose, an issue on the ground in terms of social workers' ability to carry out safeguarding investigations in private nursing homes. Parallel to this, our inspection authority, HICWA, have also expressed frustrations around the overall lack of governance and oversight for nursing home and care home residents. And I think Mary Dunyan made a very strong but a very powerful statement in 2020 around this. So she talked about how, you know, for years they've been raising the issue of the limited legal and enforcement powers of the chief inspector. So while HICWA can take action to cancel the registration of a provider or attach additional conditions of registration, this can often be a slow process. So for example, there is a 28-day turnaround right to appeal. And I suppose the other significant factor is the threshold to meet cancellation for facilities is currently very high. And I think Mary's next statement is particularly powerful in this context in terms of people should not be subjected to significantly deteriorating care and service quality to the point that their very lives are at risk because of legal limitations. So again, we can see that there are huge barriers in terms of that governance and oversight, and I suppose practitioners and inspection authorities having the necessary powers to carry out the work that they need to. I suppose in terms of addressing the problem, and again, I suppose I'm sticking to the Irish context a little bit here, I think it's very interesting and important to draw on the fact that HICWA received a 71% increase on the number of concerns or issues with the care provided to residents received in 2019 during COVID-19. And I think within that context, it's also very important to remember that often residents and families are not communicated with in a timely way around concerns or risks in a nursing home or care home environment. The current safeguarding regulations, including whistleblowing policies, are failing to protect nursing home residents and care home residents who experience abuse, as either it's not reported internally, but often ignored or stifled. And again, I would argue that underreporting must be tackled at all levels, including very much revisiting the nature of the safeguarding response and remodeling both the organisational culture and the value frameworks of staff who witness or who are aware of abuse, but allow or who participate in its concealment. And again, I think parallel to that, what's also really important is residents must be empowered to protect themselves. Again, in the Irish context, a recent Red C poll suggested that almost a quarter of people surveyed would not know where to report abuse. And similarly, the Department of Health Commission research as part of the development of their adult safeguarding national policy, which showed firstly a very low awareness of safeguarding and protection teams, and also that service users and family caregivers very much reported difficulties around reporting abuse by paid carers because, again, fear of repercussions, being labelled as difficult, or I suppose, again, identifying who to report that abuse to. So as we mark World Elder Abuse Awareness Day 2021, caring about elder abuse is caring about justice for all. As a society, we are committed to ensuring the just treatment of all people, but elder abuse violates this value. The costs of elder abuse are extremely high for the affected individuals and society alike. The losses can be tangible in terms of homes or life savings, but also more intangible in terms of dignity, independence, and possibly even their very lives. So approaches to define, detect, and address elder abuse need to be placed within the cultural context of organisations and also considered alongside culturally specific risk factors. From a health and social care perspective, unless both primary healthcare and social service sectors are well equipped to identify and deal with the problem, elder abuse will continue to be underdiagnosed and underlooked. And I think from a social work perspective, there's a particular onus on us in terms of that more preventative approach rather than the interventionist approach. So ultimately, I just wanted to finish my very brief talk this morning by saying, for me, it's in everyone's interest to care about and prevent elder abuse. And what we're going to do now is I'm going to hand over to Susan, who's going to talk to you about her lived experience of abuse within the care setting. So Susan, will I hand over to you and you can unmute, or I can unmute you. You just need to unmute your, yeah.
Sorry, I'm afraid to touch anything in case I lose what I have in front of me. Okay, good morning. My name is Susan Gaynor. And like so many other families, last year was very difficult. And I'd like to share some of my experiences with you. My beautiful mum spent 8 years in her nursing home. 7 of these were relatively happy times, but in 2019, the nursing home was sold, and pretty quickly the standard of care began to slip. It was quite evident it had now become a business venture, with profit per bed being more important than the actual care of the residents. In January 2020, prior to COVID, I voiced my concerns with the new owners. I also made a formal complaint to HICWA. Nothing changed, but luckily I was able to visit daily, so I was able to ensure that Mum was safe. Obviously, COVID hit in March, and as we all know, visiting stopped. We were not permitted to do window visits in our nursing home, except in very rare circumstances. In May 2020, one of the carers in Mum's unit asked if he could meet me to discuss some concerns he had with regard to the nursing home. He said he feared for the safety of the residents because they were so short-staffed, and told me of some rather shocking incident that had occurred. I immediately contacted HICWA. I also contacted Nursing Home Ireland, the HSE, my local TD. Whilst they were all shocked with my information, no action was taken by any of the agencies. I just wanted to give you a little background into my concerns just there. My worries started before COVID and obviously were exacerbated during COVID. Now, if I could just tell you a little bit about my mum. She was a lovely woman. She was very active prior to her dementia diagnosis, always on the go. She was such a lady and so generous with her time to everyone around her. She was really loved in the nursing home by the carers and the nurses, and she was always good for a laugh. She rarely sat still, always walking up and down the corridors. On the 21st of January, she turned 89 this year. I pleaded with the staff for a window visit, which I got. Mum was in good form. She had aged from the isolation and had lost weight, but she was content holding her baby doll and drinking her juice. I don't actually know what happened in the 4 weeks after that visit to the window, but on the 15th of February, I got a call from the nurse to say that Mum had received her second vaccination. But by the way, she'd gone downhill lately. When I inquired as to what she meant by downhill, I was told she'd stopped eating, she'd stopped drinking, she no longer speaks, she no longer walks, she needs a wheelchair. She had a skin tissue expert had to be called in on the Monday to try to repair her ulcerated feet from prolonged bed rest. I was aware from my check-ins with the nurses in the nursing home that she was not great at eating and she needed to be encouraged. Her appetite wasn't good, but nothing else had been reported to me. I received a compassionate visit on Tuesday, the 16th of February, 2021. I will never forget the state of my poor mum that day. She was so frail. She'd lost so much weight. Her lips were dry and cracked. She was clearly dehydrated. She was in bed with curtains pulled at 4:15 in the afternoon. There was an untouched dinner tray beside her bed. I was told the reason she was in bed was because she'd had a bad bowel movement and needed to be changed. So her punishment for this was bed for the night. Mum was left there until 10:30 the next morning. That's over 18 hours in bed with ulcerated feet. Clearly there was some miscommunication in the nursing home because the person in charge thought that my mum was in her chair when she allowed me visit on the compassionate grounds. So I kind of got a glimpse of what life must have been like for my poor mum, which might explain her rapid decline in 4 weeks. I took a picture of her in January and another one in February, which I would dearly love to share with you because pictures speak louder than words, but they are just too distressing to show. My mum's condition deteriorated over the following days. On Saturday, 5 days after her second vaccine, we were told she was COVID positive. We were devastated. She was so weak, she couldn't fight it. Visiting stopped over that weekend. I was offered a video call on Monday. Another vision that will never leave me. My poor mum was rolling around the bed in pain. The only relief she'd been given was Paraline suppositories. 2 days later, my mum died alone in her room. I am so angry that such a wonderful life should end in this manner. I have also so many unanswered questions, not least, how is it possible that my mum was the only woman in the nursing home in her area to test positive for COVID? The residents and staff were tested and nobody else, only my mum. Is that even a possibility? I can't understand it. I asked for Mum to be retested, but I was told that if she was retested, even if it was the same person, a second positive would mean an outbreak for the nursing home, and that would not be good for them. I was actually told that by the person in charge. My mum was sick for the weekend prior to her second vaccination. She was so weak receiving it that one of the nurses didn't even recognize who she was in the wheelchair. She should never have been put through the vaccine. I know myself, and we all know, that it can have side effects, and she just wasn't able to fight anything that came her way. Nothing can bring my lovely mum back, but I feel so strongly about the state of care for the older population in this country that I have to speak up. As you know, I run my own Montessori school, and as a private provider, I am so heavily regulated, and rightly so. I am inspected and checked by 3 different agencies. Serious non-compliance would just not be tolerated in our sector. We are doing a very similar job to that of the nursing home, just at the other end of the scale. So why then is it that the care of our beloved older people is not regulated to the same high standards that we are? This has to change. That's all I have to say.
Thank you very much, Susan, and thank you so much for sharing your story with us. I'm going to hand you back to Vivian, but thank you very much, because I know that was very difficult for you, and thank you for being brave and telling us your story and your experience. So Vivian, I'll hand back to you.
Okay. Thanks, Sarah, and thanks to both Sarah and to Susan for their presentations. And I think both have highlighted in very starkly the range of issues that we're speaking about. And I particularly want to thank Susan for it's impossible to respond really in any meaningful way. So I'll move on then to our next presentation, which is by Professor Joseph Ibrahim. And Joseph is Professor and Head of the Health, Law and Aging Research Unit at the Department of Forensic Medicine, Monash University in Australia, and a practicing senior consultant specialist in geriatric medicine. His research focuses on reducing harm to older persons and improving their quality of life. Joe has also been an expert witness for criminal and coroner's court cases, as well as the Royal Commission into Aged Care Quality and Safety. He was the lead author of Recommendations for Prevention of Injury-Related Deaths in Residential Aged Care Services, a report that followed the first comprehensive national study of injury-related deaths among nursing home residents in the world, considered one of the top 10 influential research studies in 2017, published in the Medical Journal of Australia. Joseph was also one of 3 people recognised by the Sydney Morning Herald Good Weekend's People Who Mattered 2019 in health. And Joseph's presentation is entitled Elder Abuse, the Perfect Crime. So I'll hand over to you now, Joe.
Thank you very much, Vivian. It's a pleasure to be here, and I'm grateful for the opportunity. I think Sarah and Susan really have covered the whole subject, so whatever I have to say really is just trying to put, I guess, a slightly greater context around that. Elder abuse is the perfect crime. It's something that occurs that's not recognised, not reported, not acted upon, disappears, and it's as if it's never happened. My work in aged care now borders on 30 years in clinical practice, and my patients were generally are women in their late 80s who are very polite, very caring, and will sacrifice anything for almost anyone. And I feel a real sense of responsibility that we need to speak up for them. The gist of my talk today really is to implore and motivate you to act. There is no Martin Luther King, there is no Emmeline Pankhurst in aged care rights. And that therefore requires us to demonstrate leadership and not wait for the vulnerable population that's most affected to stand up for their rights, because that will not happen with elder abuse. I want to take you on a bit of a journey in the half hour that I've got. And what I'll do is go through why there are no complaints, why no one listens, why no one acts, and how death brings resolution and relief to most people, which is where a lot of the work in elder abuse stops, and then talk about the future. Following the talk and in question time, I'm happy to address any questions you've got about the Royal Commission in Australia, and particularly COVID and sort of the deplorable effort that's been conducted nationally and internationally on looking after older people, which demonstrates a global issue, not a simple national issue. So if we go back in history, our goal was to live and to live to an old age, and that there's a detailed article in the New York Times last month describing the changes in longevity and how we've worked really hard to move from a life of 35 years to now an average one in a developed country of around 75 to 85 years. So we've worked really hard to live. What we didn't realize is that if you live a long time, you get old, and we didn't really prepare ourselves for that. And so there's the first issue, is we worked so hard to stay alive, we forgot that we really need to prepare for being older. And old age and a country with a large older population is really a country that's been very successful, typically a rich country and one that's applied good public health measures. When people talk about age and aging and wish that it wasn't a problem, I always say this is really simple. We simply stop vaccination, we stop public health measures, we get rid of potable water, we get rid of sewerage, we don't treat kids when they get an infection, and our life expectancy will very rapidly fall to 50 years, and we no longer have an aged care problem. Unsurprisingly, most people think that that's not a very sensible approach, and come to realize that being old is a success story in itself. The alternative, of course, is not what any of us want. So we come to elder abuse in this time, and it's only really been recognised formally in the last 15, 20 years. And this particular day, I think, first came into existence in 2012. So the whole notion of elder abuse really hasn't existed or been at the forefront of our thinking. And that's because older people didn't exist, and didn't exist in the numbers that we have now to make it an issue. The other thing that I think is really pertinent is that older people tend to sacrifice and forgive. Having lived a life, understanding the vicissitudes of life and the importance of either making do or patching problems up for a better future, older people tend to be more forgiving, and so they allow a lot more things go through that we now consider, and rightly so, as abuse. So the idea that elder abuse exists is relatively novel. It's been around for, I presume, all of history, but it's relatively novel in the world that we see today. But it also means we should be far better prepared to manage and deal with it. The types of elder abuse and how they get dismissed, I'll go through very quickly with you, is that someone that's subject of physical abuse gets waved off as, well, the person fell, they're clumsy, they have Parkinson's disease, they've got dementia, they don't know where they're going, their skin is frail, they bruise easily. It was nothing to do with how they were cared for, or how they were managed, or how they were handled. In terms of finances, this gets written off, well, the money was coming to me anyway, that once mum or dad died, I was going to inherit, and it'd be better if I inherited while I was young, so I could use the money to do something that I enjoy. So it makes sense that mum or dad would be okay with me taking the money now, because really it's my house, they're just waiting to die. Sexual abuse, which is where we're doing a lot of our research now, is really quite confronting, and Sexual abuse is the most underreported and underrecognized, and it fits into all of our biases and attitudes about youth and attractiveness being the cause of sexual violence. Sexual violence occurs to older people and older women particularly. It's not recognised. People don't believe it occurs because they don't even believe that older people have the capacity for sexual intimacy. So anytime an issue raised around sexual violence, it's dismissed simply on age or attractiveness, that there is no belief. So that gets dismissed again. The use of restrictive practice and physical restraints, we gloss over with a medical and clinical dressing to say, we're doing this to protect them from themselves. They may get lost, they may fall, they feel really uncomfortable and unsettled and distressed. Once someone's sedated, everyone looks calm, but sedation doesn't fix the underlying problem. So we use medical rationale to justify something that ought not be happening. And the final abuse that we often don't see, don't recognise, and don't even think it's important is not listening to the choices of the older person as to how they want to spend their day, whether they want to get up out of bed, have a shower, get dressed, what to wear, what to eat. These things, particularly in institutional settings, are highly regimented, and the person has no control over that. And when we discuss these issues in terms of control and autonomy, everyone understands the importance of autonomy and self-determination. But when you talk about you don't get to choose whether you go for a walk or not, people think that's unimportant because we don't identify or don't empathize with older people. So we have the setting already that we're not used to a population of older people. We're not used to the concept that abuse would occur. And every form of abuse, we have a ready excuse to explain it away so that we're not distressed or bothered by it. Now we come to the issue of why don't we listen? And we don't listen because, so if we recognize that we don't listen, and we don't listen because the vulnerable population that's affected are predominantly those with dementia and those of a female gender. Both groups are discriminated against in general in society, and both struggle to get heard whenever they raise an issue. And so those vulnerabilities means that if they complain or raise an issue, it's not acted upon. It's dismissed as not being important or relevant. And the biggest impact, if I say to you now, is that if elder abuse was predominantly a male issue, or if most of the residents in aged care were men, do you believe that those systems of care would be better? And most people agree if men were the primary group being looked after, things would be better. And you ask why, and people then are really silent about why. But it's very clear that it's a gendered issue, and that because it's women who live longer and it's women who need care more often because of the life journey that they've had to live through, they get ignored. And the people representing them, the carers who might be advocating, tend to be women, and they again tend to be dismissed. And you know, Susan's experience really struck a chord with me, because after 15 years of reviewing and looking at complaints and episodes that led to death, it's always the daughter that raises the issue, and the daughter's usually had to struggle for 2 to 5 years to get heard, and is usually considered to be someone that is mentally unstable, someone who has a delayed grief reaction and isn't coping, rather than people looking at the exact cause or the substance of that issue. The other reason that people don't listen is, as we get older, there's a level of disability that occurs with aging. And again, people are fearful of other. And what happens as we get older, we become other. Not only are we older, we have a disability, we may have dementia, we behave in different ways. And so we're not seen as part of the overall society. And I think that we saw this particularly with the sexual abuse of children, and that across the world, people knew this was occurring, and yet nothing was done until those children got to adult age and were able to take a stand and say, we will not be moved. This did happen to us, you must listen. And so the question I now pose is, why would we not have listened to the children when they were telling us? But now 20, 30 years later, when they're adults, we listen to what they say and before we act. So I think that's a core issue, in that as a society, we don't listen to people that aren't like us. So if no one complains, so if someone does go to the trouble of complaining and someone does go to the trouble of listening, what happens next is no one acts on it. We then get into either the regulatory or legal judicial framework with the police. And so if a person with dementia has been injured, the police officer is going to be concerned about taking a statement, whether that statement holds up, whether this is in fact a real or imagined occurrence. So they're not going to proceed as often or to the same extent as they would in another situation. What sort of witness will the person with dementia make? What sort of witness does this older person who speaks in a tremulous voice, is uncertain and apologetic, feeling that they brought this onto themselves, likely to do? It doesn't generate action. Older people also often don't want to take action because they're in a vulnerable situation where they're either dependent on the carers for their day-to-day life, or they're dependent on their children for accommodation, or they're dependent on their children for access to a social network or a life that's worth living that engages with their grandchildren. And so I've seen a number of my patients who have gone to residential care because they didn't want their children to worry, even though they were capable of living alone at home, but they choose to sacrifice their life so that their children don't have to worry. I've had another one who wouldn't press charges on her daughter, who was an opiate addict that was stealing her medication, because the older person felt responsible for the behavior of her child. And she also didn't want her child to have a criminal record, which would then affect her for the rest of her life. And so the older person then takes that on themselves. And so there is no action because the person is so conflicted by taking action. Do they lose what's left of their life? And this is where our loss of empathy or lack of empathy really plays in, because none of us know, unless we're 80 or 90, what it's like to be 80 or 90. We all know what it's like to be 5 or 6 and going to school for the first time, and how you might be nervous and scared and worried. But do you really know what it's like to be 90 and you've outlived most of your family, most of your friends? You live in a world you don't quite understand. Now someone has done something wrong by you. Where do you go? Or do you just give up? And so that lack of control and that lack of power, I think, is incredibly difficult to overcome, and one of the reasons why there is a lack of action. And then you come to the conclusion. So if you complain, someone listens and someone does act, particularly in nursing home care, but the vulnerable groups tend to be the very old, the very frail. So they tend to be old because they're very frail with multiple diseases, and so their life expectancy is relatively short. And so from the time of the incident to the time of getting to court or some resolution may be some years. And we know that older people that have been subject to any form of criminal action, about a third to a half will die within a year just because of the stress of it. So the older person eventually dies, and now you don't have a case because the person is dead. And what mostly everyone says is, well, that's a relief. They no longer have to suffer. They're in a better place. We can now move on. There is no one to complain about the case not going forward. We save time in the courts. The family is comforted because there was let's say there was a good death, and the person themselves now is free. And so we see death as a release, and a blessed release for everyone. And that's why nothing really changes. And that's why I started by saying, there is no Martin Luther King for elder abuse. There isn't someone who is marching down the streets saying, I am 85 and been a victim of financial abuse and this must stop, and I am not going away till you stop. We've had the Royal Commission in Australia, which said that 1 in 3 residents had suffered some form of abuse, neglect, or suboptimal clinical care, which I consider to be institutionalised elder abuse. So that's 1 in 3. Now, when you say, why don't the residents of nursing homes in Australia stand up and do something? The average age of a resident is 84 years. Over 60% are women. 2/3 have dementia. They're on an average of 10 medications with 3 to 5 diseases, and they need help with eating, dressing, showering, or toileting. So if your day is already taken up just being alive, you're not going to have the mental, emotional, or physical space to go make a noise about your life ought to be better. And so I think this is the only vulnerable population that exists that can't represent itself in any way, shape, or form that every other vulnerable population is able to take a stand and say, we are here, we exist, we're not going to be shifted, and society is treating us badly and we're being discriminated against. Because the issue here isn't one of elder abuse, it's simply and purely one of abuse. Older people are being treated unfairly and wrongly compared to everyone else in the population. There are, of course, nuances about how you might manage that situation, because at end of life, what people are willing to trade or forgive, what they gain, how they want their family to remain together shifts. And the nature of dementia requires a greater level of understanding about how you approach the situation. But make no mistake, the fundamental issue with elder abuse is abusive behaviour affecting older people, and it's the same abusive behaviour that affects every other person in society that has been abused. So from that, what we're left with is leadership. And here, there is no leadership at any national or even international stage. The United Nations is still working on resolutions for human rights that, as I understand, have been in train for almost 10, 11 years. Nations won't adopt standards that protect the rights of older people specifically without any explanation. But you usually will say, we already have enough rules and laws. And I say, well, if we do have those, then why aren't we applying them? So leadership is missing at a political national level. And, you know, as I get older, I didn't ever want to believe it, but, you know, if you follow the money, that's where things happen, that's where things change. And to get laws changed, you've got to get politicians to act. You've got to demonstrate that there's a cost to society, a financial cost to society that is worth addressing in terms of elder abuse. And here you hit another barrier in that you don't count as a person in public health once you hit the age of, be it 65 or 72. There's a cutoff as to what your life is worth when people are calculating quality adjusted life years. So the old aren't counted in terms of public health, and they're not counted in terms of society. And so the question is, what will motivate people to change to address this problem? And I say that we need to stop talking about older people per se and simply talk about social justice for all. And whether I'm 100 or whether I'm 50, the rules of law apply the same to me. And I expect that when I get to 90, that those rules will be enforced with the same vigor that they are for others. Where this change is going to come from, well, I think ultimately it's going to come from the middle-aged daughters that have been badly labelled as being vexatious and emotional. They're the ones that hold the truth, and people are only just starting to listen. And almost every time you look at either a hospital scandal or a nursing home scandal or anything where there's been egregious behaviour, typically there's been a female nurse or a daughter who's spoken up about this, and they've persisted. And I think that that's really unfair for that to be laid at the feet of a small group of people. And I think if there's one thing that we collectively do is the pressure needs to build, and we need to try all avenues. There's no single fix for how we address elder abuse. The definition from the WHO, UN around it being in a trusting relationship needs to go, because it's not just about a relationship between family, friends, or neighbours. I think the later definition that Sarah raised from the US clearly showed that there is a breach of trust at an organisational and national level. And if we were truly honest, we would say that there's institutional elder abuse occurring in the majority of countries in long-term institutional settings. COVID demonstrated national elder abuse in failing to plan for COVID. And we had warnings, particularly in Australia, we had warnings about COVID. And the early studies from China told us that people over the age of 80 with multiple diseases were the ones that were most likely to die. And that population is readily identifiable, and they're the residents in every long-term care home in every country. And every country has failed abysmally, generally, to deal with that. And the reports from Amnesty International into the UK, into Belgium, Sweden did its own investigation, Australia had its Royal Commission, Canada has a special inquiry, New York's looked into their own management of nursing homes, and there's a call now for, I guess, a COVID inquiry. And I think COVID has highlighted what has been hidden for so long. Elder abuse occurs, it's institutionalized, and we have accepted it. And, to my embarrassment and shame, I started off in aged care because I wanted to do something to help older people. As a trainee doctor, I physically restrained, chemically sedated patients because that was the right thing to do. And we were all proud of the job we were doing 25 years ago. We've moved far too slowly in recognising the human rights of older people and recognising that clinical care needs to be much better, and the improvements that are possible in aged care have not kept up pace with what's improved in healthcare. Healthcare's transformed in the last 20 years with evidence-based practice, with a just culture, with recognition of teamwork, with recognition of clinical governance, with recognition of open disclosure. All of that's recognised in health, and yet it doesn't exist in aged care. And so aged care is at least 20 to 30 years behind health. In terms of dignity of risk and choice, we're at least 30 to 50 years behind the disability sector. And so these are really quite shameful things to consider. But we've got to face up to that hiding from it is not helpful, and hiding from it is not being grown up. I don't like what I did 20 years ago, but I did that. I can't run away from it. I have to say times have changed. I have to be different. And so we have to be different. Just because we care doesn't make us good. Good intentions will not get us to where we need to go. We need to think long and hard about the next step and have a concerted approach, and not allow the regulators or the politicians or our governments to continue to get away with what is egregious behaviour that wouldn't be tolerated. And so if you ever hesitate for a moment, think about the same situation, and instead of a 80-year-old woman with dementia, substitute a white, middle-aged, middle-class politician, and then say to yourself, what do you think would happen in that situation? And why is that different? And if you can articulate that difference really quickly, you know there's something wrong, because people aren't being treated fairly. So with that, I'll leave you, and happy to take questions, but we're past talking. The time really now is to act, because if you're lucky, you'll get old. And if you get old, you're going to get some diseases which might make you vulnerable to someone abusing you. So if we don't fix it now, then we will reap those rewards when we get older.
Okay, thank you very much, Joe. Another very clear, very insightful, thought-provoking and hard-hitting presentation, as has her previous ones been. If I can take just two very quick takeaways among a whole lot of takeaways from what you said, for me, what resonates is there is no Martin Luther King, on the one hand, advocating in this area. The other positive side, if you like, is that as far as we in this virtual room are concerned, the leadership that you spoke about that needs to happen is in this room, and we're all people who can take action, which, as you say, is required after the certain level of talking that we had. So thanks very much again, Joe. I'll move on now to the third presentation of our first session, and it's by Bernadette McNally, who is independent chair of the Safeguarding Board for Northern Ireland and chair of the National Independent Review Panel. Bernie graduated from Queen's University in Belfast in 1985 as a professional social worker, having previously completed a BSc in psychology at the University of Ulster. And since then, Bernie has worked in the Northern Ireland Health and Social Services in a variety of practice and senior management positions, spanning both adult and children's social services. In 2012, Bernie was seconded to Northern Ireland Cooperation Overseas to work in Eastern Europe with national government administrations on a number of childcare projects. This work involved assisting in the development of modern childcare policies, procedures and practice in several European Union accession countries. Just before Bernie starts, just to remind people, if you have questions, to get them into the Q&A box on your screen, and also for anyone who's tweeting, it's hashtag WEAAD. So Bernie, thank you very much for being with us here today, and you have the floor. Thank you.
Thank you very much, Vivian, and thank you for that introduction. First of all, I'd like to say good morning to everyone and to say how delighted I am to be here this morning. And I just want to thank talk, and also to thank Susan for sharing her story, which was really very emotional and very important for all of us practitioners, professionals and policymakers to hear from the front line. That's probably the most important thing that we take away from today. I'll just share my screen, and I have some slides. Some people say people who have slides have no ideas, so hopefully that's not the, if I could just start from the start. So my talk this morning is about learning when things go wrong, and I just want to give some of my background so that people understand where I'm coming from in terms of the reviews that I do. As Vivian said, I'm the independent chair of the Safeguarding Board for Northern Ireland, which is an interagency partnership that was set up to ensure that the statutory and some voluntary agencies that were charged with the important work of safeguarding children, like police, social services, education, etc., that they work together to safeguard children. So one of the statutory functions of the Safeguarding Board is to review cases where things have gone wrong. I'm also the independent chair of the National Independent Review Panel in the Republic of Ireland, and it is for adults. So it again has a role to inquire into and review cases where things go wrong in situations where there are adults involved. I suppose the main difference between the two, and this is probably a difference between children and adults really, is that the Safeguarding Board in Northern Ireland is a statutory, it has been set up under statute. They have a statutory duty to cooperate, and all of the agencies work together to review cases. Now that's not their only function, but that is one of their statutory functions. And I have an independent line right through to the Minister in the Northern Ireland Assembly. So I'm independent of all the member agencies in that regard. As I say, we have a statutory duty to carry out these reviews. So there's no ambiguity. Cases that require reviews must be reported to the Safeguarding Board, and then we have a criteria for deciding which ones we do a review. In the Republic of Ireland, and this is the same in the North as well, where adults are concerned, there's no statutory duty for agencies to do this. So when I review cases in the Republic of Ireland for adults, and it's particularly relevant today when we're talking about elder abuse, this is a single agency non-statutory process. So I don't have any powers in that regard. But the National Independent Review Panel in the Republic of Ireland was set up following the Grace case. And people may remember the Grace case in the southeast of the country, and relating to a young woman who had intellectual disabilities. And I suppose that from our point of view, from this talk's point of view, the main issue emerging from that was that they didn't have an independent mechanism. The HSE did not have an independent mechanism for reviewing such cases. So the National Independent Review Panel, which I chair, was set up as a result of that. And I do have a level of independence in that I report not to a director in the HSE, but to the chair of the HSE Quality and Risk Committee, which is part of the HSE board. So why do we need to do independent reviews? Now, I suppose it's important for me to say that a review is not about an investigation. It's not me going in to find out what happened. It's to go in to find out, excuse me, it goes in really to find out why it happened. And the main motivation for examining why things happen is to provide service improvement. So there's no point in examining a case, examining governance, leadership, all the various issues that usually lead to these cases happening, without coming back with some improvement process. And I was struck by what Joseph said earlier when he talked about the system having to change. And I firmly believe that very few people come to work to do bad deeds. Social workers don't come to work to do bad deeds. Nurses don't come to work to do bad deeds. And of course you may have rogue people, and I have come across many rogue people in my day, but mostly I find that and my recommendations usually relate to systems failures. And those systems failures, I firmly believe, relate to the quality, relate to the model of care that we have for, particularly for people who are living in residential homes, living in nursing homes, whether they're for older people or for people with intellectual disabilities, learning disabilities. Because a colleague of mine once said, even good people do bad things in institutions, because the culture of those institutions, and Joseph mentioned when he was a junior doctor, administering sedation, etc. And that's because people come into those situations, the culture of the situation, the culture of the system, the way they work, particularly if they are junior member staff, they have very little power of control to say, well, actually, I'm going to fight against the system. I'm not going to do that, but that everybody else does, because the culture of those organizations really push people in that direction. I think we also have to do reviews because the public confidence depends on not so much, I'm very much against we have a bit of a shock jock up here in the north. Stephen Nolan, people from Northern Ireland on this webcam will know him. And I'm not sure it does anybody a service to sensationalize these situations, to have people on talking to because I don't think that we can instill public confidence in that way. I think we have to, the public require or demand of us that we provide them with assurance that these situations are being examined, that independent people are looking at them, that changes are being made, that models of care are changing, and that the situation is leading to an improvement in quality. It's not good enough just to come on to a radio station and complain, and then everybody walk away again and nothing changes. You really need to have a systematic approach to these matters, to look at what happened, to examine the case, to change the model of care, and to make real improvements. I think also, why do we do these reviews? And I think both in the north and the south, in the safeguarding board where I am in the north, and in the independent review panel, I think you do need a standard infrastructure for reviewing cases. Quite often a situation develops, particularly happens in the adult side, that we have abuse in care homes. We have a situation which develops, which everyone knows is wrong. There's the users have been abused, the families are outraged, quite rightly, and we just send it out to somebody who perhaps has been retired for a number of years, perhaps someone who has a bit of time on their hands, and ask them to review the case. And there's no structure to that review. There's no, the terms of reference are usually cobbled together in a crisis, and people go off and review the case, and then they come back with this report that everybody thinks is rubbish. And people think, well, there's not much can be done about that. And the crisis has been averted, the situation has moved on, and people rarely go back. So I think it's really important that you have a structure, that you have an ability to set out terms of reference in a way that actually looks at what went wrong, and actually has a mechanism for recommending significant change, not 100 new documents, not 100 new tick boxes, not in, I've seen reviews that have 50, 60 recommendations. I worked in systems, I was a director in the Belfast Trust, and you get the recommendations, and most of them are about a new policy or a new procedure that needs to be put in place, and it becomes a very bureaucratic exercise that people just go through to get to the end of. The boxes are ticked and people move on. Whereas I firmly believe that at the end of a review, you really need to look at how do you change the system or the model of care that allowed this situation to go on for so long. I think it's really important that we have a safe mechanism within the system to look at things and go wrong. And I remember when I was a young social worker working in childcare many years ago. In fact, I was a team leader, and we had a child who died at the hands of a brutal murder. And the impact that had on me and my staff, to this day, I don't think about that child every day, but I think about him a lot. And you know, the impact that that had on me at the time, the impact it had on, and many of that was about, could I have done more? Could I have, what happened? Was there something that I did? Was the system wrong? And staff who don't have this mechanism, when there is not a mechanism in place to look when things go wrong, you find that the most junior staff are the ones who are absolutely dismayed. I'm involved, or I was involved in a review recently, and I'm very conscious when I'm talking about examples that I'm changing them slightly so that I don't identify any of the places where I'm working or have worked in the past in terms of doing reviews. But I was working with a situation where an older woman working, living in a care home was brutally raped by a member of staff, and we know that these are not one-off incidents. We know that this has happened to other residents in that particular situation. But when I visited the staff to talk about the review and talk about the terms of reference for the review, the staff were absolutely distraught. And the people who were the most distraught were the people who were closest to the resident. And, you know, I think that it's really important that when you do reviews, that you support everyone involved in this, because everyone has a part to play in helping us understand not so much what happened, but helping us understand why it happened. And if we don't have a mechanism for doing that in a safe environment for staff, then all we do is cover up. People don't tell us what we need to know. People don't talk to us. So we really need a mechanism. An independent review also encourages reflection, and you know, it's, as Vivian said, I'm a professional social worker by background, and you know, reflection is a really important part of our work as to what we did, how we did it, and could we have done it better. And of course, the most important part is a review should provide strategic oversight for the people who can make the changes, who can change the model. The care assistant in an older person's home cannot make the changes. These have to be made at a strategic level. The model of care in older people's homes must change. Institutions, in my opinion, are inherently dangerous. They're inherently dangerous. So you cannot change that unless you change the model. You cannot change it just by saying, oh, we must put in more monitoring, we must put in more inspectors, we must put in those days those ships have sailed. We're not, in my opinion, we need to look at the model of care. I've already said this shouldn't be about public humiliation, and they're not about criminal investigation. Those are processes that need to happen with the PSNI here in the north and Garda Síochána in the Republic of Ireland. These are simultaneous investigations. They can go on as long as you work closely with the police. Much more difficult, I think, in the Republic of Ireland, where there's not an interagency approach to these matters. In the north of Ireland, it's a much more interagency approach, so you can sit down with the local police and social services and other agencies and make sure you're not tromping all over each other's patch, if you like, and make sure that what the review's doing is not in any way impinging on the police's ability to investigate these matters. Nor should it be used for disciplinary processes. There are already processes in place to do that, and they should be carried out, and where a member staff or a manager or senior official requires to be investigated under, there are well-worn processes for doing that. So we work alongside in both the children's side and in the adult side. We work alongside these processes, but we're not primarily, our role is not to contribute to them. I just wanted to outline from the panel's point of view in the Republic of Ireland, our mission, and it is about promoting learning. It is about best practice. It's about improvement to services, and it's about trying to prevent these situations happening again. And unless we come at it from that perspective, we will not learn, we will not change. Because if we come at it from always being an accountability mechanism, which is the criminal part of it or the disciplinary part of it, if we don't do the learning bit, we won't change. And all will happen will be the good people will leave these services because they'll feel that they have no way of changing them, and they will and they'll walk away. They'll go to somewhere that they feel that they have some more power, and I think that would be a disaster for everyone. So purposes, you know, put in this purpose of what happened. Most of the time, whenever I come in, the what has already been established. So I was doing a review a while ago, and it related to a woman. It was a mental health issue, and a woman who had mental health illness took her child's life. This is quite a common thing now. Took her child's life and then took her own life. And this has happened both all across the country, and it's an increasing issue. And I suppose that had already been established. The facts had already been established. There already had been a police investigation, and there was an ongoing coroner inquest issue. So we were looking at how could this have happened? And this woman was known to the services. She had actually told her medics and that was her intention, that she was going to do that. And the whole issue of how could that have happened in that environment, and she was in a mental health institution, the relationship with the child's father, all of those issues were all really, really difficult. So trying to get this situation to be person focused, to be person centered, to find out what went wrong and why. It's mostly about the why, and to identify some potential for change. You know, some of the principles that we have about confidentiality, which is really, really important, trying to understand how can you do this and keep the dignity and of the person, for example, and the privacy of that. And how can you be open and transparent, and at the same time trying to get the staff to talk to you without creating an environment where the media and others are really having a field day with the case, because these crises become very sensationalized and they are absolutely horrendous. They are absolutely horrendous. But it's how we fix them is the thing that I am really interested in. There's a couple of things and really important that we get the terms of reference right. It's really important that we have natural justice and fair procedures, that if we are talking to staff, that we can protect them, that we can look after them, and we give them a right to reply. And of course, the report has to be of high quality. And just to finish off, I just wanted to identify some of the key issues. How do you avoid a blame culture when these are really terrible things that people have done? So how can you balance that, the terrible things that have happened with this learning, what we're trying to create, which is a learning environment? How do you protect the privacy and dignity of the service users and their families whenever you're trying to expose wrongdoing? And there's a couple of things that struck me about that. You know, I was doing a review recently in a residential home for people with intellectual disabilities, and when I spoke to the families of the victims, they were split down the middle. You know, some of the families wanted this exposed. They wanted a prime time story on it. They wanted everybody in the world to know. And they thought that's the only way things change. If you expose it all, it'll change, and you know, people will be held to account. On the other side of it, some family members said, "No, this is re-victimizing us. The sexual abuse is a really stigmatizing thing, and if you expose it all in the media, then our families become very, very exposed and be re-traumatized." So how do you manage all these expectations of the various stakeholders, and how do you share that learning? So I hope that this is a sort of like a whistle-stop tour of the National Independent Review Panel and the Safeguarding Board in Northern Ireland, and sort of giving you sort of a difference between the adult side and the children's side, because they're both, you know, they're quite different. And I suppose just the key points again is that we want to create a learning environment. We want to protect the victims, if you like. We want to protect their families. We have to balance between exposing these matters and getting this learning out there. And it's all about, and a big thing for me is that there is no statutory, in the adult world, neither north or south, there's no statutory requirement to have these reviews and to look at these matters. Whereas there is, and certainly in the Safeguarding Board in Northern Ireland, there is a statutory obligation and a statutory duty to cooperate by all agencies. So thank you very much indeed for allowing me to share some of my experiences with you.
Okay, thanks very much, Bernie. And again, once again, a fantastically clear and insightful presentation there. And really, I felt it provided us with a very clear framework, almost like a handbook or an A to Z of overview, review, and investigation of the areas that we're talking about. So, and with the various issues on improving and preventing and developing good practice and so forth. So thanks again, really fits in very well with the overall collection of presentations. Okay, we have a few minutes for some Q&A. I'm not sure if I'm picking up the right questions, but either way, we can always, we have a further opportunity later in the day, but I have identified a couple of questions that I might put. And one is, some of the questions that I've seen coming through are overlapping. Maybe this one might be for either Sarah or Bernie, but anybody can feel free to take it. And Pascal Moynihan and I think a number of others have highlighted the issue of the need for legislation, as some of our presenters have referenced as well. So in terms of, as Pascal said, he feels that appropriate legislation helps to shape the values and the culture and the practice and so on. And in terms of adult safeguarding legislation, how big a feature or how important a plank is that in what needs to happen from here on out, if anybody wants to take that up?
Okay, maybe I'll go first.
Yeah.
Vivian, I suppose just from my position and position the Irish Association of Social Workers, I suppose we feel very strongly that we do require primary adult safeguarding legislation. I think our experience from social workers on the ground and also HICWA, our inspection authority, has been that they cannot do the job that they need to do without a legislative basis and without the necessary legal powers. And again, certainly in the Irish Association of Social Workers, we've been actively engaging with politicians around this issue to try and advance this, particularly within the context of COVID-19, when people were essentially cocooned into nursing homes without any contact with their family members, those vital monitoring eyes. And I suppose we certainly felt within the context of COVID, there should have been legislation fast-tracked to address this gap, given that we knew that older people in care homes and other care home residents were very vulnerable within the context of COVID. Bernie, I'm not sure what your thoughts are from the north.
Yeah, well, I suppose, I have experience of legislative framework in both children and adults. And children, it's much easier with children because children, under the age of 18, there's a statutory duty to investigate child abuse. There's no barriers to that. When you try to replicate children's legislation into the adult world, it's much more problematic because the adults, for start, they have consent issues that perhaps are not as relevant in children. In that sense, children obviously have a consent principle, but it's not as relevant. So you have to make sure that you don't try to replicate children legislation into the adult world. Is completely separate. And I think that the biggest problem is that, and I think Professor Ibrahim sort of touched on this, is the voice of people, older people, people with disabilities, people with mental health issues. They are really down in the lower ranks of society in that regard, in terms of allowing their voices to be heard. So the legislation at one level, okay, you can put in lots of legislation, but if they're not empowered to have a voice, the legislative framework won't help them. The empowerment to have a voice is the most important thing. And I think that legislative framework should be built, you know, that to give them a legislative voice. I also think that the relationships between the agencies, one of the things that I think is the most important part of the Safeguarding Board, for example, is that there is an interagency partnership, and the legislative base around that is a legislative duty to cooperate. So you must share information with each other. So if I, for example, am involved in something in the Safeguarding Board, and it's not necessarily about reviews, because reviews are a very small part of what goes on in the Safeguarding Board, but if I'm involved in something and the police, for example, say, we're not telling you, we will take them to the court now I've never had this situation, because they know that we will take them to court to get the information. So there's a statutory duty to communicate with each other and to cooperate with each other. Now, if I was to do the same thing say in the Republic of Ireland, if I'm doing a review, for example, on in a nursing home, and I ask the guards for the information, they won't tell me. If I ask the Education Authority, they won't tell me, because they use this GDPR, which is crazy stuff. They use the GDPR as a barrier, this has created, they've given them the perfect tool to refuse to cooperate and refuse to share information, and it's total nonsense. The GDPR was there to stop Google from sharing our private information, not to stop the police and social services from talking to each other. So I think that we need to really be clear what legislative framework do we want? What are we actually asking the government to provide? And I don't think we're clear on that. Just to say we need a framework to investigate adult abuse is not good enough. We need to figure out exactly what we are asking this legislative framework to do. And I'd say the most important thing that they have to do is share information with each other, because they're not doing that at the moment. And that's across the whole island of Ireland, and I'm sure across other parts of the world as well.
Yeah, I was going to say, Joe, do you have any thoughts on it from the Australian kind of context around legislation and where that lies? And do you feel that's important or not?
I think legislation is important, but I think you need someone who's got the guts. I'm assuming that's a familiar term in Ireland, who's got the guts of Bernie to follow up and make sure that the law is followed. I think that I've often been involved in cases, particularly in where investigations are limited, and that the people running the investigations may not be using the full force of the legislation behind them. You need the rule book, but you also need the person who's applying the rule book to be applying that with some vigor and integrity. And so legislation in and of itself isn't enough, but it's crucial that it be the starting point. And Australia's had a number of law reform commissions into elder abuse. And what we've uncovered is that there are different, I guess, groups of thinking about mandatory reporting versus voluntary, and issues around consent. But these issues won't be sorted out unless we actively say we need a law, and what will that look like? And I think that's the foundation, but it's not the end of it. It's, do you have the workforce? Are you going to equip people to actually do the investigations and then enforce and apply the sanctions that are needed? And one of the major failures in all regulatory arrangements pretty much across long-term care across the world has been either weak regulation, weak investigation related to the regulatory agency, or failure to apply sufficient sanctions to get behaviour change. And so it's really a very integrated system.
Thanks very much for that. Clearly, I think the answer is yes, that it's not necessarily the be all and end all, but good legislation and the enforcement of it is a key element. I might just squeeze in another question because we're coming up against time in terms of taking a break. But a number of people in the Q&A or in the chat and Q&A areas have made a very interesting comments, suggestions, helpful hints, experiences they've had. But some people referred to the model of care that's used or tends to be implemented or in place, particularly for older people. And Mandy Cowden asked a question that some of the panel might like to address in terms of practice. What would a good model of shared living look like? Should we look at cooperation and real community-based options? And there was a reference to what's described as positive shared care. I suppose it's exploring or challenging some of the existing models of care provision that we have in place at the moment, certainly in Ireland, and have people got views on how that might be different and better? Does anybody want to have a go at that?
Well, could I just make a couple of points on that?
Sure, yeah.
I think congregated living, we don't need any more reviews to tell us that this is a disaster. That we've had years of child abuse in those institutions. We've had the Magdalen laundries. We've had children's homes. We've now got lots of evidence on old people's homes. We've got lots of evidence in these big hospitals. There's no more, we don't need any more research to tell us that these places are not good and they are inherently dangerous. So we have to find, and Professor Ibrahim talked about us all, we're all hopefully, we're lucky heading for old age. And I don't want to be in one of those institutions because they are inherently dangerous. So we need to figure out a way of increasing the amount of support that we give to people living in their own homes. I'm not saying their own homes are not dangerous also, but they're less dangerous. That people need to have the support to live in their own homes with community care. But if they have to, if they require to be in residential care of some sort where they have to move out of their own homes, it has to be in some sort of individualized living arrangements where they, again, do not, that they have access to the outside world, that they have access to their families, to visitors, and that the staff that are looking after them are well trained, well cared for, or well supervised, that they have appropriate training. At the moment, I heard a story recently where a friend of mine's daughter was applying for a job in a residential facility, had absolutely no experience, wanted to do this for like a summer job, and was told to start on the Monday morning. Now, how can you start on the Monday morning when you've never done this in your life before? And how many people are starting in these institutions on a Monday morning without any training or qualification or experience? And they go in and they're like Professor Ibrahim, they go in and they're like the junior doctor, they just do what everybody else is doing, because this is how these institutions are run. And I remember going to the children's home one time, and there was locks on the kitchen doors, and I said, why have I got a lock on the kitchen door? Oh, because we don't want the children eating food, during the day. We just want them to eat food at meal times. Now, what normal family situation has locks on their kitchen doors and only eats food at meal times? Like, these are crazy rules that develop in these institutions that they're there to keep the institution running. They're there to keep the culture of the institution running, but they have no purpose in terms of protecting the individuals. So I think there's lots of good practice models. There's an institution here in Belfast, and whenever I was working in Belfast many years ago, and we were trying to close this older person's home. It was a 40-bedded unit. It was a terrible place. I thought we needed to bulldoze it down and start again. We had all the political, because there's jobs involved in these institutions, there's money involved in them, there's big business involved in them, and we had everybody in the world fighting against us, and we had lobbying going on to stop us from closing this and bulldozing it down. We had the Stephen Nolan show every day. When we eventually closed it and we created this environment where we had, and this is for people who had dementia, every single person has their own self-contained apartment within this new facility. Every single person has their own home, and we use technology, we use other ways of monitoring, and it is a fantastic place. And I was visiting it recently. I had some overseas visitors and I brought them to it, and they could not believe, and the residents, the families, everybody, a fantastic model. Costs a little bit more, but this sitting around the walls, institutions, they have to close.
Okay.
Yeah.
Okay.
Can I
Sorry,
just
Sarah.
add in one point, Vivian? Just,
Yeah.
I think it has to be said, and Bernie's kind of touched on it. I think, in Ireland in particular, we've moved to a for-profit model for the provision of nursing home and care homes. There is an inherent conflict of interest when we're going down a for-profit model in terms of care. And really, for me, our nursing homes, our older people need to be much more integrated into our local communities. So this othering of nursing homes and care homes needs to stop, and they really need to be a core part of every community, rather than separate to it. So sorry, I know we're really stuck for time. So
all right,
yeah,
that's okay. Okay, listen, thanks very much, Sarah. Really important point though. And we're just going to take a break. Just before I do that, I want to thank all our speakers in the first session. Bernie McNally, obviously, Professor Joe Ibrahim, and Dr. Sarah Donnelly, but I do particularly want to single out Susan Gaynor, and just to paraphrase or quote Maya Angelou, who said that people will never forget how you made them feel. And I'm sure I speak for a lot of other people at this event today. And I certainly, and other people, I think, won't forget how Susan made us feel today, which has been a really important part, as have all the presentations been. So I really want to thank all of you for your input today. And it's been really inspiring in terms of the inputs. So we'll be taking a short break. I'm going to clarify with Sarah how long that is, but
15 minutes.
15 minutes. So it's 10 past 11 now. So 5, 10, 15. I'm not good on the maths. 25 past 11 sharp. We'll be back.
Sharp, because we're
sharp.
behind
25, 11, 25, whatever way you call it, or 25 past whatever hour you're currently at in your relevant country. And I have great pleasure to hand over after that break to Michelle McMaster, my colleague, to chair the next session. So thanks everybody, and enjoy the short break.
Thank you.
Hi, Michelle.
Hi, Celine. You okay?
I keep forgetting to put the headset on.
Hi. You
Oh,
okay?
that's better. Yeah. It's good morning so far. Anyhow.
Yeah, it's very good.
Michelle, just to say, we're probably okay for time in terms of we've left a good bit at the end for Q&A. So don't stress too much. We can still give all the presenters the time they need, okay? And we're having some problems with the chat function. And we weren't able to send the questions to Vivian via chat, but Sinead will read them out if you prefer.
Fine.
Yeah, is that okay?
No, that's absolutely fine. I've been able to see most of what's in the chat,
Oh, great.
and I'll keep a wee eye on it as well. So there'll be a lot more than we can cover, but everyone who's all listening at the minute as well will know we'll not cover everything, but I'm sure we can come back afterwards to anything that's outstanding.
Yeah, and actually maybe just let people know as well that Joe's happy to, or he's put his email in the chat and he's happy for people to contact him directly as well.
Yeah, thank you.
And good luck.
When everyone's not visible, it's hard to see who all's back and who's not at the minute. So I'll give another minute. It's not quite 25 past yet.
Yeah. And Sarah's here, who is our next speaker. So that's the most important thing.
Okay, so I think we will go ahead. Yes. Excuse me, bad start as I clear my throat, but welcome back to everyone. It has been already an outstanding morning and so much information, so much more to take in than you can in one sitting. But I think the important thing is knowing that we have this conversation and we make it louder and we keep it going and we continue it. So I'm certainly looking forward to the second half of the session and the speakers we have lined up. Thanks to everyone in the first half. We'll name them all again at the end, but everyone has known the value of that. In the chat box, just for anyone who hasn't seen that, Professor Joseph Ibrahim, who had to leave, has left his own email address, so anyone can contact him via that to follow up any questions you might have after his presentation. For now, we want to hand over to Professor Sarah Ryan, who is with us, and it is lovely to have you here, Sarah. Thank you very much. Your topic is public issues and private troubles, so I'm just going to introduce Sarah with a little bit of her background. Dr. Ryan is a professor of social care at the Manchester Metropolitan University. A sociologist by background, her research focuses on learning disability, autism, and social justice. Her current research interests also include scholar activism and patient safety issues. Professor Ryan recently led an influential campaign raising awareness on the treatment of learning disabled people following the preventable death of her son Connor in 2013. The campaign, #JusticeForLB, received a Liberty Human Rights Award in 2016 for highlighting the systemic failings in the investigation of unexpected deaths of learning disabled people and people with ill mental health. Professor Ryan, you are very welcome. It is great to have you with us, and I will simply hand over to yourself. Thank you.
Thank you. Let me sort out the slides. Thanks to Sarah for inviting me, because it's not quite on the topic of elder abuse I'll be talking about here today. It will be around learning disability, but I think there's a lot of learning that transfers across. So I hope people who are here, particularly people in Ireland, Northern Ireland, are aware of what happened to Connor. And I'll be talking a bit about that today. But what I wanted to start by doing is to mention C. Wright Mills, who was a US-American sociologist who wrote a classic in the 1950s called A Sociological Imagination, which is really good read and has stood the test of time extraordinarily. Now, C. Wright Mills was a firm believer that knowledge properly used can lead to social change. And obviously, we're not using our knowledge very well at the moment because, as we heard in the first session, these abuses continue to happen and are endemic. Now, Mills made a distinction between private troubles, which are things associated with the person, with their own limitations, their character traits, something about them that sort of is somehow flawed and troublesome, and also public issues, which are things that should matter to all of us, that are really important, things like the social injustice that Professor Ibrahim mentioned this morning, you know, that these are things that are really important to the fabric of society. Now, what C. Wright Mills is doing here is really making us think about what are private troubles and how many private troubles are actually private troubles or personal troubles, and how many are actually public issues being framed as private troubles. And so I quite like this distinction, because when you start to dig a bit deeper and think about what constitutes a private trouble, is it somebody who's on benefits, who spends their money on 40 cigarettes a day? Is that a personal trouble? Is that a private trouble? Or is it because they're living in a sort of cramped, damp flat that they're really desperately struggling to manage daily life, and the cigarettes are just one outlet for doing something that makes a difference to them? So when you start to really think about it, there are very few private troubles, and there are a lot of public issues, but it works in favour of the state to frame a lot of stuff as private troubles. It's your own fault. So that's the underpinning point I wanted to make during this presentation. So coming to Connor, and a very personal detour here, really. This is Connor, one of our children. We have 5 children, with his siblings, and these photos show a bunch of kids, basically. And this is what's so stark, the contrast between what happened to Connor externally to his family and our family life, where Tom, his younger brother, the little baby lying on William's back in the bottom picture, didn't find out Connor was actually autistic till he was about 9, and he was at a friend's house, and the friend's dad mentioned when they were watching something on the telly that Connor was autistic. And I think that's a really important point to make within families. And we've heard in this morning's presentations with Susan, and also some of the other presentations, the importance of these family members, the importance of families in trying to get to the bottom of these catastrophic, neglectful, cruel, abusive situations that happen. And these pictures, to me, just capture why this is. It's because in families, people are people, and they're just loved. So there's Connor. There was a film here, but I won't show it to you because I can't bear the screen sharing. It's such a nightmare. I can't bounce to a YouTube channel. So this is just, you can just enjoy the photo of Connor up on the mountainsides in Wales with his dog, his brother and his brother's friend. And again, it's just a wonderful photo of an extraordinarily loved and beautiful young man. So central to the story I'm telling you is the blog I wrote anonymously. I started in 2011, and it was a series of just reporting funny episodes that happened during the day, because life around Connor for us as a family, within the family home, was hilarious and so much fun. And every day we just laughed so much, all of us. And we still don't know if Connor was being deliberately funny, whether he was just a natural comedian, or just, I think, his take on life was so unusual that it just brought riches to our everyday interactions. So I started jotting them down on this blog post that was really for family and friends, but developed to much wider reading because of the humour that was contained within it. So here's just one example for you. There's so many favourites. I mean, I kept the blog I wrote on a daily basis for 2 years before things started to go wrong. And there are all these examples, but this one here around Connor, the school diary was the mechanism for hearing about Connor's day from school. And then at tea time, I generally sort of chat to him about what it had said. And he'd had his meal prep that day, and he was supposed to make kebabs, but he didn't have a skewer, and so he ate bits instead. And it was this sort of just this funness really around life that ends up being erased in the same way that as people grow older and they go into residential care in their 70s, 80s, 90s, their humanity is erased, and the humour goes as well, and they become, as we said earlier, just people living to live a day at a time. Now, Bernie's talk, I was very interested in the reference to the sort of media coverage of stories and does this make any difference or not? And I can remember at the time Connor died in July 2013, and it took 8 months for him to make it into a national newspaper because he didn't count, and he never counted outside of our family and friends and school teachers and some staff. And so it's very unusual to get newspaper coverage of a young person with learning disabilities, although that is increasingly changing over the last few years. So I think it is actually quite important that these stories are covered. And so this was, like I say, this was the first time Connor made it into the national newspapers, and I don't think he barely touched local newspapers for a good 7 or 8 months either. On the day Connor died, he was in a ATU, an assessment treatment unit. He was just admitted for a few weeks. It was sold to us as an exemplary place. It was an NHS unit. There was something like 21 staff. There was 5 patients. There was almost 4 staff on duty. There was a whole, I mean, you would think it was like going to a spa with the top world's leading sort of manicurists and massagers and everybody in there. Their dog was going to sort of sort out why Connor had become uncharacteristically distressed. As it was, time drifted on, and there was the vague care he got at the beginning, which was minimal, sort of had gone by day 107 when he drowned in the bath, basically. He had epilepsy, and they changed his medication in the unit, and he was susceptible to medication change. He actually drowned with 2 members of staff doing a Tesco's order online in the office next door, which is something that I always say it, I can't quite get my head around that level of carelessness. So I posted this one-liner on the blog and was contacted by a barrister because people have been following the blog, so we're automatically elevated beyond the position of a lot of families who will never get that email after something like this has happened, to say you might want to be aware that the NHS might not act in the way you think they'll act over this. You know, it's another devastating thing to hear and quite unbelievable at the time. But within 2 weeks, the NHS trust involved had actually published online in their board minutes that a service user or a user had died of natural causes and all the processes and systems were in place. And this comes back again to the discussions this morning about legislative and regulatory processes. These are ultimately meaningless if they're misused or ignored. And also this slide here also speaks to, and I think Susan's, and it was mentioned earlier again, the micro abuses and the microaggressions that switch to the families who call out this stuff, or to the staff who call out this stuff and stand up and say this is something is really badly wrong here. You find yourself under a sort of spotlight of being basically people trying to take you down because they don't want this stuff to go any further, which is again, there's so much unbelievable in all of this. It's quite extraordinary. So we then went on to have a whole series of months of blaming mum. It was always my fault. The campaign we went on to run, that I'll talk about a bit in a minute, was really problematic. Apparently it caused all sorts of harm to families in the county. The psychiatrist who now is bouncing around Ireland in practice still described me as a toxic woman and worse. And the blame, and it's a really interesting process because for a long while it was as if I was a single parent bringing up a single child, and they stripped back the family, the sort of happiness, the joy, and it was a pointless blaming exercise because you cannot blame somebody outside of a NHS care for the death of a patient in their care. You know, it's completely ridiculous, obscene, grotesque to do it, but it happened. We even had a abusive phone message from within the trust. And to come back to Bernie's media point, which, you know, I do think the media coverage is important, but it was really grim that we published this, we made everything public, everything was transparent with the campaign. The second we published this, we had every news channel ringing, come on the news and talk about this call, and this call isn't the story. the story is what happened to Connor and why it happened, and yet this was the salaciousness. So there is that aspect, but overall I would say that the media coverage and the sensitivity that journalists have treated us with has been quite extraordinary. So what happens then? How do you resist the personal trouble narrative? Because already Connor was a user, he didn't have a name anymore. He was a learning disabled person. He was troublesome. He had epilepsy. He was somehow limited. You know, people always die early with a learning disability. This was, you know, one of those things that happened. He obviously died of natural causes at 18 because that's what people do. How do we resist this narrative? How do we make something that is so not on the public radar actually a public issue? And so we set out, George Julian, a journalist and freelance consultant, and I sort of, with the support and help of so many different people, set out to try to campaign for making what happened to Connor a public issue, basically. So social movements and a set of informal interactions between groups, people, places, on the basis of a shared collective identity. Now, we learned that the shared collective identity in our campaign, which turned out to be extraordinary, was humanity. That we're all human, and I think that was what the presentations earlier were alluding to, the fact that the people who have grown much older are human, and we're all human, and we're all heading that way. We're all heading towards our older age if our lives are successful enough to grow to an old age. So then we've got the social media aspect of what happened. The fact I was writing the blog in the first place, and this whole new space that's opened up, and again the tweets already from this morning's sessions are amplifying the discussion, is sharing it wider, it's generating discussion, and so on and so forth. It's allowing a new community of activists to sort of get together to connect, and it's allowing us to use knowledge properly, as C. Wright Mills said, to sort of say, this is a public issue, this is a human rights issue, this is about social justice. So we've got our hashtag, which is the start of any campaign these days, Justice for LB, because Connor was known as Laughing Boy. And we had no rules, we were pretty anarchic, there was lots of swearing, lots of joy. And we said the ground principle to the campaign was the fact we had to raise £25,000 to get legal representation at Connor's inquest, while the NHS Trust ended up with 6 or 7 legal teams, different barristers that we all pay for in England under the NHS with our taxes. Bereaved families have to pay for their legal representation for themselves. And it costs around £25,000, which most families don't have accessible. So one strand of the campaign was to raise money for the legal representation we needed, and the other strand was to raise awareness around what had happened and to make this a public issue, but to be joyful. That was we didn't want to have photos of Connor, the photos as Susan referred to this morning, the photos of her mum that are so awful that you can't share them. And I agree with that, because I think it just perpetuates this idea that people aren't human. And so we wanted to capture the joy. We came up with a manifesto because we were banging on Twitter, and we eventually got on an appointment to meet the chief executive of NHS England, which was quite something. The night before, Rich, my partner, said we better have we can't just go and tell our story, because that's not going to do anything. We need to go up there and make some demands about what we're trying to do. So we came up with a manifesto that's online if you Google it, and we wanted justice and accountability for Connor and for us. We wanted sort of medium range aim around the trust and the local authority, the people who commissioned such a sort of hellhole, to be held accountable, and wider issues around the position of people with learning disabilities in the UK. And again, this interesting points, listen to Bernie's talk around it. To me, it's not about blame, it's about accountability. If somebody punched somebody in the street and they, or stabbed somebody in the street, there is going to be some sort of process in which there is accountability. And I don't think that being in a care setting should protect staff from acts that are clearly wrong. And there was a comment in the chat earlier around criminal. So because of the reach because of writing the blog, and a lot of people were following, we sort of ended up with reaching all sorts of people just by tweeting and sharing the hashtag. And we asked for somebody, could anybody provide a flyer for us to say what we were trying to do? Within about 20 minutes, we had this beautiful flyer to share. Connor absolutely loved buses, he loved social justice, he loved travel, he loved London, he loved Ireland. He had all sorts of things that he passionately really liked. And so people started sending in pictures of buses, and they got kids to draw pictures of buses, and we've ended up with so many pictures here. People did different activities to raise money and raise awareness. There was a party where somebody made Connor cakes in the shape of a bus with his face on the front. We held parties. This cardboard bus here was made by a friend's family, and they took a photo for one of the days. We marked all the days that Connor was in the unit, 107 days. Each day was adopted by different people, and there was a lot of artistic coverage of it all. And so that was their photo for that day. The campaign spread. It went to Glastonbury twice with a flag of Connor, which was got onto the front of the BBC website. And the flagpole broke, and the family took it around and just photographed people holding the flag up. Catherine Runswick-Cole there on the left of the photo in the blue dress took the flag to New Zealand, and that's the New Zealand Commissioner for Human Rights holding up the flag and talking about the human rights of people with learning disabilities with self-advocates. And the bottom picture is an American academic, well, he's Australian, but he was in America. Mark Sharry put in a motion at the American Sociological Association to say that what happened to Connor was wrong. Again, it's putting that flag in the ground, making a stand, and passed a motion that there would be a presentation event, a session at the following conference in Chicago. So we went out there and gave a talk about what happened to Connor, and other academics talked about abuse in settings and the sorts of things we're talking about today. So you can see these people did all sorts of different actions, tiny actions, really massive actions. It didn't matter what they were as long as they were positive. One of the highlights of the whole campaign was that we took that cardboard bus I just showed you, and we went on the Camino in Spain, and we walked the Camino with some self-advocates, holding the bus, getting the bus out, talking to Spanish people about what had happened. The 3 self-advocates that came with us, two of them hadn't had a passport before, they'd never been abroad. We crowdsourced money to pay for them to go and to pay for 2 supporters. And we ended up on Spanish telly because Spanish people just could not understand what we were saying. I don't think they couldn't understand that people could be treated like that, because culturally that just would not happen in Spain. So then we come back to the sort of legislative type processes. And again, we talked about this. This was discussed earlier this morning, right? Legislation's in place, we've got regulatory processes, we have a coronial system, but in actual fact, how it works is brutal for families. And here's a picture I drew early on to show, and in fact, this was very early on because we have various meetings leading up to an inquest where there was just the trust barrister, solicitor, medical director, legal person there. And there's me and Rich on the other side with a box of tissues. We would not have understood any of the discussions that were going on, the various submissions that were made. At the actual inquest itself, there was 8 interested parties altogether, 7 of which were related to the NHS Trust. You know, it's just extraordinarily disempowering processes, even with the support we had behind us. And by this point, we'd raised the £25,000 to have legal representation. I've just put this slide here because I think that it's really important to understand these micro abuses that happen on so many different layers in these situations. So these various photos, the top one is waiting in the family room for the jury determination, which was neglect. But the battle to get to that point, to actually get the neglect determination, was enormous. You know, the scarring that happened along the way. The delays, the time it takes, the waiting, as our dog Bess, waiting interminable processes to take place. And then this extract here was from when you go to a inquest or a hearing, you actually get told that you need to, we would ask you not to wear denim sportswear or trainers. It's like all the rules, you're heaped with rules. about minutiae, about stuff that really doesn't matter, whereas the rules that should have kept your loved ones safe have been obliterated. And here you are being told not to go along in a tracky bottoms at a hearing that you should never be at. And I think that this again is the C. Wright Mills, it's the pinning down this stuff. It's not accepting these prescriptive practices for families who have been devastated. One of the outcomes of Connor's, of going to see the Chief Executive of NHS England was he did commission a review into the deaths of people in the trust, because we were appalled by that natural causes statement and thought, well, of course Connor didn't die of natural causes. He was getting in the bath before he went to visit the local bus company. And yet they say no, natural causes, well, that's what it is then. And so there was an investigation that was a whole story in itself. That found the most catastrophic findings it found all sorts of findings. Again, I would Google this and have a look. But there were 327 unexpected deaths of people with learning disabilities in the care of the trust over a 5-year period, and 2 were investigated. So you can talk about legislation, you can talk about regulatory processes, you can talk about reviews or whatever. But if you don't count, if you're not seen as human, you don't even get on the review table. So 325 people died unexpectedly in an NHS trust, and there was no investigation into their deaths. So anyway, so the story went on. We ended up with a health and safety investigation, who eventually, after pressure from the then care personnel, who basically told them to investigate Connor's death because they weren't going to, brought a criminal prosecution against the trust. And by this time there was a new chief exec and they were sick to the back teeth of anything to do with this. They pleaded guilty before there were any charges. And then we had a period of a week while the judge decided on the determination. And at this stage, it's important to say that because it was a criminal prosecution, there were, the judge could fine the trust anything, because it was an NHS trust. We were warned that the fine would probably be negligible, and we had to try to steer ourselves to not thinking that this was a price for Connor's life and a price for the other patient whose the case was brought, the prosecution was brought about, TJ. And so we had a period where we were sort of saying to everybody, it's not the amount of the fine doesn't matter. And again, this comes back to what Bernie's talking about. So if they find the trust £200,000 for the death of these 2 patients that were utterly preventable, and in fact, if they'd actually acted on the findings from TJ's death, Connor would never have died. It's what the judge says that will strike a blow across other trusts and force them to sit up and do things differently. But as it happened, the trust were fined $2 million, the biggest fine in the history of the NHS for Connor's death, and Teresa Colvin, who was known as TJ. So we sort of got accountability. We got there in the end through the collectivity and the way in which people stood up and did stuff. Now, I just wanted to, I've got some final reflections that are in part reflected to based on what's been discussed this morning. So it's it was a bit of an ongoing process, this presentation. I didn't have an end slide till about 2 minutes ago. So I just wanted to throw these reflections out here to bring it back to the elder abuse and the behind closed doors. Let's just make sure I haven't forgotten anything I was going to say. No. Okay, so it's clear from this morning's talks that there's a varying drift to abuse across the life course. Some people are subjected to abuse from childhood and onwards. Some people, like people with learning disabilities, are going to be abused. We had the figures this morning from Australia, didn't we? And most appalling figures. And then you get to the later stage of your life, and the chances are you may be subjected to abuse with the statistics and research underpinning this. So we're all heading that way, basically. And abuse, and it doesn't matter how many times we say, we just need to change a model of care, we need to do this, we need to do that. It obviously doesn't work. Abuse is tolerated and even accepted. And I think there's too much apology that bounces around, releasing people from actually thinking they have to do anything. And one thing that sticks in my craw, basically, is bystanders. And I would say that the day after Connor died, we didn't receive this document for months, thank goodness, because I think it would have destroyed me. the trust actually circulated a briefing about my blog to an email list of at least 7 or 8 people. All the names were redacted. So it went to all redacted. And you get the email, when you do subject access request or freedom of information, you get the whole email exchange. So you get the various replies and the responses. So this email went to all these people with a briefing about my blog after the death of our son. And not one single person replied to that email to say, what the fuck are you doing? Why have you written this document? Why are you sharing it? Not one single person. And I think that these bystanders, the people who don't act, who allow the stuff to go on with the excuses that they don't really see it anymore because it's cultural, I just don't agree with that. And I think that's really problematic. I think, as I probably said, the lack of humanity ascribed to the abuse really is bringing them back to personal troubles, private issues. This person's just troublesome. And this extends to the family. This mother's just vexatious. Oh, she's such a pain in the ass. She's so difficult. She's toxic, actually. You know, it's an incredibly powerful mechanism to use, and people accept it. And I don't really understand at what point are your goggles so foggy that you would accept the stuff that is shared with you, all the stuff you see, all the stuff you're told, unquestioningly. And then finally, the micro abuses and aggressions, as I've said, extend beyond the closed doors to the family members and staff. My staff, secondary to me, I'm afraid. Where are you, basically? The extraordinary resources needed to gain accountability reveal the flimsiness of legislative and regulatory processes. If I hadn't written the blog, if the barrister hadn't got in touch with me the day after Connor died to warn us what would happen, we would have just fallen into an abyss. And Connor would have just never, he would have always been just another learning disabled laddie who died early. I think we all have a responsibility, and I think this is what Prof. Joe was saying earlier. We all have a responsibility to stand up for people's rights. With people, if people can't stand up themselves, it's our responsibility as citizens of a society to stop slumbering and stop letting this go on. And I think we need to stop blaming it on the system, because the system is ultimately people. That's it. I'm done.
Sarah, there are no words that can reflect, I'm sure, on behalf of anyone here, the impact that will have had on so many. You're not just an academic, a professor working in the whole field of social care, but you're a mum and a family member and have been through that heartbreak. And it follows on from this morning's story to simply reflect the fact that this is not about older people in one setting, people with learning disabilities in another setting, children in another setting. It's about humanity. I think you've reinforced that really clearly. This is about humanity. And it follows from the comments again from Professor Joseph earlier, when he said this is about social justice for all. And I think that message is loud and clear today. That was moving, very powerful and very honest. And I think that's why everyone is here today, so that we can collectively not just talk anymore, but find ways to stand up. Your last words there, we all have a responsibility, and we all need to simply not stand back and watch and speak, but we need to stand up and make change. And hopefully this is a good start to that. So thank you, very sincere thank you for broadening that out and covering that whole topic. Really appreciate it. Thank you. We are now going to hand over to Eddie Lynch, who has shown his face on the screen again. Thank you, Eddie. Lovely to have you here. I'll just read out a little bit of an introduction to you. So Eddie Lynch is Commissioner for Older People in Northern Ireland, and you started your appointment in June 2016. Prior to that, Eddie was the Chief Executive Officer of the Age Sector Platform. In this role, he was responsible for managing the organisation's staff and supporting the board, committees, and wider membership in its policy development and campaigns work. Eddie joined Age Sector Platform in February 2008, having previously worked at the Consumer Council for 5 years, where he was the head of Consumer Affairs. And Eddie's topic this morning is Home Truths, creating stronger protection for older people in care settings. And I know this will follow on very nicely from anyone else. So Eddie, hand over to yourself. Thank you. You're on mute just at the minute. There you go. Thank
I'm
you.
on mute for about the 1000th time in the past year.
Thank you. We'll stop counting.
Thank you, Michelle, and thanks for the invitation to speak at what has been a really fantastic webinar this morning, and really excellent presentations and really powerful personal stories from Susan and Sarah particularly. So it's a tough act to follow, I have to say. I think some of the stories we've heard this morning have really hit home the importance of why we're here today and we're speaking on this issue. For me, World Elder Abuse Day is always an opportunity to reflect on how we are protecting or not protecting some of the most vulnerable people in our society. And it always gives us an opportunity to come together and see how are we doing things, how well are we protecting people, or how well are we not, and what else do we have to do. And clearly there's a lot more that has to happen. I'm going to talk briefly about my role as Commissioner for Older People in Northern Ireland, because I know many people on this call probably aren't aware of my role as a Commissioner, and talk a wee bit about my powers and duties and how I go about my work and some of my experience in dealing with elder abuse and supporting families and older people who have unfortunately suffered across the many forms of elder abuse that unfortunately exists. The role of Commissioner was created almost 10 years ago now in Northern Ireland. It was created after older people themselves lobbied for many years to have a commissioner to represent their interests, but also a commissioner that would have strong legal powers to take action on important issues. And Northern Ireland wasn't the first, but we were the second to get a commissioner for older people. Wales was the first, and Northern Ireland was the second. And I've been in post since 2016, just started my second term last June. And the real role is to be an independent champion on behalf of older people and to safeguard and promote older people's rights, and really to advocate, provide statutory advice to government on any key issues, as I see it, that affect older people. So I have very strong legal powers. The legislation actually gives me very strong legal powers to carry out investigations, both formal and informal investigations, to issue guidance on best practice, carry out information research, and really my role is to provide advice to government on the big issues that affect older people. And in doing that, I have a number of legal duties as well to promote positive attitudes towards older people, to encourage participation from older people in policy making, and to review any services and legislation that affect older people in Northern Ireland. I also have a legal duty to promote an end to discrimination against older people, encourage best practice in how they're cared for, and have a role in advising the Northern Ireland Assembly, the Secretary of State and relevant authorities on any matter that I believe is a big issue. So that's just by way of background, what the role, an oversight commissioner role like myself has. In terms of World Elder Abuse Day, I mean, we know abuse comes in many forms. It can be domestic, financial, physical, sexual, psychological. And over the years, and my 5 years in this job, we have dealt with a number of many cases, unfortunately, of elder abuse in different forms. The main areas that we have dealt with have been in relation to care homes and care home settings. And I did an investigation into one care home, which I'll talk a bit about briefly in a minute. But the other big issues are scams that older people are abused by, and that's a big issue that affects many thousands of older people every year. And also the issue of financial abuse, which mainly is carried out by somebody within the family, which makes it a very difficult issue. And my office carried out research on this a number of years back, which showed that actually 1 in 5 older people had experienced some form of financial abuse as well, which is quite a high figure. In terms of care homes, much of my advice in relation to government policy position comes from an investigation I carried out into a care home just outside Belfast, Dunmurry Manor care home. This investigation, I kicked it off in early 2017, February 2017. It ran to June the next year when I published the Home Truths report. And that investigation was very extensive. It looked back from when the home opened in 2014. And it came about because a number of families reported some major concerns about their loved ones' care in that home. And when I looked into it and spoke to authorities, I wasn't convinced that the issues the families were being raised were being treated with the level of seriousness that I felt that they deserved. And I kicked off an investigation which looked at the actions of the home and the homeowners, but also the actions of the Department of Health, the regulator, the RQIA, and 4 of the 5 health trusts in Northern Ireland who had actually placed residents in that home. So it's quite an extensive investigation. And it was because of my legal powers that I was able to carry that out. I was able to request all documentation in relation to the home so it could be reviewed. We carried out many dozens of interviews with staff, ex-staff, with the different authorities, the department, the regulator, the trusts. And that painted, unfortunately, a picture where we found a home that had really struggled since it had been set up. And the result of that had been many years of poor care and treatment of the older people in that home and real infringements of their human rights. And that led to the Home Truths report, which had 61 findings and 59 recommendations for change. And most of them were not about just the home itself, but actually they were about systemic change within the system that I believe needed to happen if we were to better protect older people across the board and make sure that we didn't have this scenario playing out in the future again. So for me, many of those recommendations have been progressing. Government has accepted them, and unfortunately, it does take time to bring about change. But there has been change happening within the system, and still many other areas are being progressed as we speak today. But there were clear gaps that I saw, and some of the top line issues for me was the poor legislation that we had placed in Northern Ireland. And we knew this from before with our own casework, that many of the authorities who were tasked with protecting older people and vulnerable people were dealing with legislation that was outdated, was fragmented, was difficult to use, and it didn't allow authorities to take swift, effective action in many of the cases that we saw come into the office. So one of the things that I called for was new adult safeguarding legislation. And the good thing is that the Health Minister last year announced that he would bring forward a new piece of legislation, the Adult Protection Bill, which is currently going through the process now. And I think that's badly needed to help all the authorities and all those who are tasked with protecting and supporting people. One of the other big failures in the system, as I saw it, was the complaint system completely failed. Despite many of the residents in that home having very strong advocates, family members who were looking out for them, who were raising the issues, raising the concerns, their genuine concerns, those concerns time and time again hit a brick wall. They weren't followed up, or they were followed up, but it still didn't get to a stage where they were acted upon and issues resolved. And in our request for information in relation as part of the investigation, we actually saw emails from people in different authorities, from people in trusts who were sending issues saying there's a major problem with this home, we need to do something about it. So there was many people within the system who recognized there was problems here. But the bottom line was those problems weren't elevated to a level that something was done about it. And despite 23 inspections in 36 months, the system did not find the levels of failure of care that I discovered in our investigation. So that was something that really failed families and residents. And I believe that, you know, sorting out legislation, of course, is really important. The regulation and inspection regime is important, but the families are the ears and eyes on the ground, the people who are in homes on a daily basis. And they're the first often to see things going wrong. And what we need to have a culture in our care homes where people who have concerns are encouraged to bring those concerns forward, talk to the management, talk to the staff in the home, and have an attitude that if you're not happy with the care your relative's getting, we're going to sit down and talk and address the problem until you're happy. When I was invited to speak today, one of the things that struck me was the name of this webinar, Behind Closed Doors. And it reminded me of some of the interviews that we did with family members of people in Dunmurry Manor. One particularly stood out to me. It was a man in his 80s whose wife had been in that home for a number of years. He came in and spent 2 hours pouring his heart out to my investigating team and explaining about the concerns he had about his wife's care in that home. And he felt guilty because he hadn't raised it. And he hadn't raised it because he said, I know she's in there, she's vulnerable. If I make a fuss, I'm scared that when the doors are locked and the lights go off, she's in there alone with no protection. And we heard that from different family members, and there was a lack of any sense of trust in the home, trust in the system. And I think that's just, it's really heartbreaking that people felt like that, that they couldn't speak up or they could get punished for speaking up. And that's a culture we certainly need to erase from any home where that exists. We do need a stronger regulatory and inspection regime in place. There's no doubt about it. We need something that picks up things, that follows concerns more rigorously and robustly. And I believe there is an appetite for that. You know, I've spoken many times in recent months with the RQIA. I think there's recognition that there needs to be changes and we need to bring them in. And I also think we need, you know, we just need better communication with families as well. You know, there are many, many good care homes out there, and many people will report very positive stories about how well their loved ones are looked after, how well the home communicates. But there are clearly some homes where that doesn't happen. And that is something, again, that needs to be tackled. And also, we need better conditions and support for staff. You know, one of the big problems in this home was the huge turnover of staff. They had 10 different managers in 2 years. That should have been sending warning signals left, right, and centre that something was wrong in that home. But we also had a huge number of agency staff, people who said they went in, they found problems, they found it a very difficult place to work and didn't want to go back. And we need to have a system that captures that when a home is failing, when a home is struggling, that action can be taken more quickly. In terms of really just to sort of come on to the pandemic, and I just want to reflect maybe on the last year particularly, because the last 15 months, because that has had a major impact on older people in many ways. And I think this day has added poignancy this year because of the battle that older people have faced since COVID hit our shores in early 2020. Older people have had to really take extreme measures over the past 15 months to protect themselves and reduce their risk. And as a result of that, there will be many more older people who have put themselves at more risk of abuse as a result. So, for example, you know, we know already that older people who are lonely, who are cut off from social contact, are more vulnerable to becoming the victim of a scam, whether it's a telephone scam or an email scam, postal scam. So with people being shielding for the past year, that has made them already more vulnerable to abuse, as well as people who may be living in domestic abuse situations, because that doesn't stop at any age. And unfortunately, that's a big issue for many older, particularly older women. And that's something that, you know, lockdown will have affected as well. But I also think that we have to, you know, look at what COVID and the pandemic has brought to us. And I think one of the things that it has highlighted, it has shone a spotlight on ageism in our society. We saw the care homes as probably the most obvious area where, despite what we'd seen across Europe, in Italy and France and Spain, and the terrible stories we had been hearing about care homes and the impact COVID had once it got into those settings, many of the care homes here were left as sitting ducks. They didn't have the support available. They were trying their best, but I know for the first many weeks and months, we were working on a daily basis with homes who just simply could not get PPE, despite their best attempts. So there are question marks for sure in any future inquiry about why did that happen. Of course, we were worried about protecting the NHS, protecting our hospitals. We were very concerned that we didn't have a health system that was overrun. But why was there not the same level of focus on the group of people who we knew at that stage were most likely to fall victim to this? And we knew that the setting where COVID liked was care homes because it was just almost impossible to control it once it got in. So we saw slow provision of PPE, a slow rollout of testing, and possibly the most crass example that I would give about ageism in the pandemic over the past 15 months was right back in the first couple of months when we had those very grim daily death figures coming out of people dying. And the first 6-7 weeks, those figures did not include deaths in care homes. And I found that appalling that the deaths of people in care homes was not being included in the official statistics. And it called for government to change that for many weeks before they eventually did. What message did that send? Did it send a message that the lives of older people living in care homes was as valuable as anyone else? I don't think it did. And I think one of the other things I just want to reflect on is the ageist commentary and statements that we saw too often in the media at times and in the press. I'll give a couple of examples. Some of you will remember these. The Daily Telegraph had an article where one of the reporters wrote that COVID-19, and I quote, "From an economic perspective, COVID-19 might even prove to be mildly beneficial in the long term by disproportionately culling elderly dependents." Now, that was an article written in a national newspaper. And I would point out that the average age of Daily Telegraph readers is 61. So, that sort of acceptance that even penning that to paper is acceptable. I think it's an example of some of the ageism in society. I also was on radio programs where I heard commentators talking about these restrictions are ridiculous. So the average age of people dying is 82. In the sense, well, they're at their end of their life anyway. So therefore, the rest of us can't be made to take these restrictions. So, and there was other things about maybe older people's lives being less valuable, really quite disturbing comments from people and quite senior people in different parts of public life. And I think there was also an attitude, and we're still seeing this, of older people in the community, shielding away. And there was, particularly in the last 6 months, when the growing voice of people wanting to get out of lockdown, people were saying this sort of what I would call the out of sight, out of mind mindset, that, okay, older people are still at risk, but why can't that group stay at home? Why can't the vulnerable people just stay at home and let the rest of us get on with our lives? And, that attitude was not, it wasn't given any recognition of the contribution that older people make to society. Both, in many ways, in volunteering and childcare, but also in the economic input they make as well, which is massive and will continue to grow as we have an aging population. So really, in conclusion, that's my thoughts on this day and reflecting back. Certainly, the pandemic has highlighted again for me just how many occasions elder abuse can exist across our society. And it's often said that the true judge of a society is how it looks after its most vulnerable members. And I think on World Elder Awareness Abuse Day, it's important that we do, as a society, embrace that view and do everything we can to protect and safeguard older people from all forms of abuse and to protect their human rights, no matter what age people are at. And I just hope that someday in the future, we won't need a day like this to highlight the abuse of older people. So thank you for the invitation.
Thank you. for that, Eddie. That has been another incredibly valuable perspective. It's also a very different perspective than some that we've heard already. And I think that's one of the reasons why a day like this at the minute is still so important, to hear all those perspectives, variations, etc. I think one of the challenges that you have highlighted there is about the pace of change on that legislative level and at the governmental level, etc. And everyone here is very well aware of that. And I think it's too easy sometimes to condemn without understanding that that's also there to safeguard the end result. So I just think it's a lovely balance to what else has been said. There is a question for you in the questions and answers, which we'll come back to at the end if there's time, which is about the Adult Protection Bill. But for now, thank you. That has been, as I say, a very different perspective, a really important one, and very valuable to hear those insights from your perspective as Commissioner. So thank you for that. We're going to move on now to our final speaker, but by no means least important, Celine, just so you know that. Celine O'Connor is joining us, and I'll give you a little introduction to Celine. Celine graduated from University College Dublin in 2001 as a professional social worker, and subsequently completed a qualification in systemic psychotherapy with the Clanwilliam Institute. Since then, Celine has worked in the Health Service Executive in both adult and children's mental health services. She was part of the Elder Abuse Service that subsequently developed into the Safeguarding and Protection teams. Celine currently manages the Adult Safeguarding and Protection team in Community Healthcare, Dublin, South Kildare, West Wicklow. This team provide a direct social work service for adults at risk of harm in the community. They also have oversight of safeguarding plans being developed by older persons and disability services. The team also provides safeguarding training for professionals and services, and Celine is also an active member of the IASW. So I'm going to hand over now, Celine. You've got your slide up there, which is showing up well, and your titles, Challenges and Solutions from the Frontline, a Social Work Perspective. Thanks, Celine.
Thank you very much, Michelle. I hope everybody can hear me okay, because I'm on a borrowed laptop and trying to work around new systems as a result of the cyber attack that we've experienced in the HSE for the last while. I'd just like to thank ISW and Sarah Donnelly and BASW for the opportunity to come and talk about the work that we do as social workers in the Safeguarding and Protection team. But I'm also representing the views and opinions from our Adult Safeguarding and Protection Special Interest Group as ISW. I've been blown away by the presentations already this morning, so they've been reflecting so much of what I wanted to talk about, so much of the experience that the teams and social workers who are providing that frontline safeguarding services have experienced. But really the personal stories are the piece that goes to the heart of the work that we do, that we are all about relationships, working with people and hoping that we can be a support to them. I know the Commissioner there, he finished with you know, the measure of any society is the way that it treats the people who require its care. And I'm starting with that very same line. You know, Ireland's history of institutional care has not been a happy one. We have a legacy of abuse that has been recorded in our children's homes, industrial schools, Magdalen laundries and mother and baby homes. Many of these have been the subject of reviews and reports, and the state, as we know, have issued apologies, but also then disputed their responsibility for what occurred in these settings as they were run on behalf of the state by other bodies, predominantly the religious ones. We are now moving increasingly into a situation where we have an older person's residential care industry, and that's what it's becoming as an industry, being predominantly funded by private bodies and increasingly by large global companies. We've had a year like no other when a global pandemic has focused attention on how we treat and care for those who are older and more vulnerable in our society. The ISW have long held concerns about the premature entry of people into long-term care because of the lack of appropriate resources and supports in their community. And we've been framing aging and illness as nearly personal failures, because if we call out the institutional and policy failures at the root of them, it would mean we'd actually have to do something about it. And I know, as Bernie talked about in her example earlier, sometimes when we have to do something about an issue, it's going to cost more, but the value actually is massive. Ireland is an ageing population. we're all getting older. This is on a very selfish level. This is a really important piece of work we should be doing to protect our own futures. So where are we on our journey so far? You'd be delighted to know I'm not going to talk about all the 150 years since the Lunacy Regulation Act was established in the Republic of Ireland. So I have a whole list of important dates, but the reason why I've included our 150-year-old regulation is because that's the one that if you come for an interview for a safeguarding team, we'll expect you to know this legislation, because this is the only legislation that we have to protect adults. And this legislation only protects adults who've lost capacity. We are very eagerly awaiting the full enactment of our Assisted Decision-Making Capacity Act, and that we know the decision support services are also being set up, and we're very keen to have those in place. I'm just going to briefly pull out some of the things. We've had lots of primetime reports, we've had lots of reviews, we've had ongoing investigations. A lot of the ones that I have referenced in there, those reports have not been published yet, they're still ongoing. There's lots of costs and expenses involved, and the HSE or other bodies doing reviews. And I suppose one of the disappointing things is that a lot of the reviews that have started, the reports aren't published, so there hasn't been that learning out there into the public. So we have, what we often find in Ireland is that when there's a scandal, there's a reaction. So in 2005, there was the Lees Cross Nursing Home primetime report. And in 2007, the HSE established the Elder Abuse Service. In the first year of the Elder Abuse Service, there were 27 social work posts and 927 referrals in year one. The following year, that doubled to 1,840. We then had in 2014, the Primetime Iris Attractor programme was launched, and the HSE then launched its policy on safeguarding vulnerable adults. And in 2015, the teams were set up. So the teams were made up of the elder abuse social work services. And we were given one extra principal and one extra professionally qualified social work. So we were effectively staffed for 54 social workers. And in that first year, there were 8,033 concerns of abuse reported. So I'm just going to talk a little bit about the policy that we operate under. You know, it's a very, very brave policy. It was a public declared no tolerance of abuse. And actually, I'm going to say that that is one of the absolute strengths of this policy, that in Ireland, we decided that we wouldn't operate a threshold system. So any concern of abuse needed to be reported to the safeguarding and protection team. And I think that was something, because as a country, I think we've seen how tolerant we are of abuse. We're really tolerant of the abuse in our mother and baby homes, in our schools, really in all walks of life. The principles that were underpinning the policy: respect for human rights, a person-centered approach to care and services, promotion of advocacy, respect for confidentiality, empowerment of individuals, and a collaborative approach. Because we all know you can't just safeguard by yourself. It's not just a social work role, it is everybody's role. However, social work do have a lead role to play. How do we safeguard? With consent of the older person. We work based on the will and preference of the person and not the principle of best interest. So, you know, we hear a lot about, well, you know, we should keep them safer, so we need to medicate them, we need to lock the room, but that's not what we want. As an older person, do I want to take the risk of not having a fall, or to take an opportunity to go out and walk to my local shop and buy the paper? And I think a lot of that is what we've seen during COVID, is people wondering about cocooning older people. Has that been in their best interest? Or would they have liked an opportunity to take the risk to see family members? We work to reduce the risk to the older person, but again, that's in line with their will and preference. If somebody wants to take a parachute jump, then we will facilitate them in the best way of doing that parachute jump. We work in a person-centered approach, and I think one of the things when we talk about language is, and when we talk to staff and we talk to other people, person-centered should be about the person. who you're supporting. It is not about the staff. A lot of times we're hearing such confusion about what person-centered is. And when we ask staff, well, tell me how you take a person-centered approach, it becomes, well, I do it this way and I do it that way, and I do this for them and I do that. But it's not about what the person actually wants. We've been doing quite an interesting review in a service. And one of the things that they say talked about person-centered approaches, and actually what upset staff quite a bit was a really small thing that they couldn't give, if a resident woke early in the morning, they couldn't give them a cup of tea or a slice of toast because the kitchen was locked. It was against union rules, be taking somebody else's job if somebody else made a cup of tea or provided a slice of toast. And these are the small little pieces that, you know, I think Bernie mentioned the kitchen being locked, and it's the same thing happening in our older person's room. If somebody likes tea and toast in bed at 7 o'clock in the morning, that should be facilitated. Collaboration is key. We all need to work in partnership. We all need to talk to one another. We've heard this morning a lot about, you know, how we don't talk, how we hide behind GDPR. And it is so important that if we communicate well with one another, we will be able to safeguard older people much more effectively. The safeguarding and protection teams, we directly assess complex cases in the absence of other services. We directly assess cases referred in the community setting, and then we review and agree safeguarding plans that are provided to us from our HSE and HSE funded services, and they are older persons and disability services only. And what I do want to do is acknowledge the work of the designated officers that are based in those services, who are the ones that are doing that active safeguarding on the ground, and then safeguarding teams have oversight of that work. We also support other services and professionals who aren't covered by the policy to assess the concerns and to put a safeguarding plan in place, and we provide training. We had hoped that today our 2020 annual report figures would have been launched, but again, due to the cyber attack, we have unfortunately had that delayed. But this is just a brief snapshot then of the types of concerns that have been coming in this is 2019. We do know that during 2020 with COVID, that some of the figures will have dropped because a lot of services were unable to submit reports. We had some services who were saying they were too busy with COVID to report concerns of abuse or to follow them up. But by the end of the year, the figures were coming back up. You can see there's quite a huge number. So for people over 65 and up to the 80s, we are talking about just under 6,000 cases of abuse that have been reported in. And I know Professor Joe was talking particularly about sexual abuse. And again, our sexual abuse figures for older people are rising all the time. Previous years, they were at 1%. They're now up to 3%. And again, what we hope is that's a result of the training and input that have been going into the services to identify the concerns that people are recognizing and finding signs and supports. About 83% of victims of older sexual abuse reside in an institutional care setting, such as a nursing home. About 80% of the time, the perpetrator of older person sexual abuse is a caregiver to the older person. Throughout COVID-19, we've been very concerned. We've been continuing to assess the allegations of sexual, emotional, financial, physical abuse in community and organizational services. And that has been a challenge, but the teams have adapted and worked around it. There's been a lot said about the legislation and our ability to access private nursing homes. We don't have any legislation. As I mentioned, we have our 1871 Lunacy Regulation Act. So we do struggle to gain access to homes in general. So it doesn't have to be a private nursing home. Having said that, during COVID, we have seen a lot more engagement from private nursing homes who have contacted us directly looking for support, advice, who have engaged voluntarily in doing safeguarding, following our preliminary screening processes and providing safeguarding plans, and who have asked us that we would come direct into their units and directly work with the residents to provide a safeguarding plan. We have had long-standing concerns from ISW about the lack of not just social work, but other health and social care professionals in our private nursing homes that will provide, you know, the different skills and help in reducing people's risk of abuse and deterioration on both the physical and emotional level. But what we have heard from other speakers is, you know, that sort of intervention isn't valued. There are very few psychologists, very few social workers who work directly in older person services. We talk a lot about the culture, why abuse is underreported. You know, when it comes to our staffing, we saw from Iris Attracta, you know, that there were 10 staff, I think, were charged with abuse, but there were plenty of other staff who were recorded by that program who provided really good quality care and support. But yet, how do you balance that? How do you balance that you allow some of your colleagues to abuse and yet you do go in and try to do your best job? We have training, what we permit, we promote. So you see if you know, I often say to newly qualified social workers, when you start a job, it's really important that when you come in, that somebody says to you, not this is, forget what you learned in college, we're going to teach you the way we do things here. It is so much more valuable for a social worker or for any of us going in to have somebody say, well, oh, you've got all the new learning. What do we need? How can we improve our service? What we see a lot from staff is one of the reluctance to report things is that they're going to get their colleagues in trouble. They fear losing their own job. They fear the impact it's going to cause. They don't believe it. They don't believe that older people can be abused. They don't believe they can be sexually abused. So therefore, if you don't believe that, why would you report it? One of the key messages that we'll give out in the training is believe. If you start with believing, if somebody says, I've been raped, believe them, follow your process for a sexual assault, because that's going to very quickly let you find out whether it is true, whether there's a medical reason, whether it's a delirium. But if you believe, that is the best place to start. We have a huge amount of concerns about the language and the minimizing of it, the, you know, loyalty, liability, livability. And a lot of our safeguarding social workers and social workers working in disability and older person services have told us about the challenges they faced with the culture. They have been, when they have tried to raise concerns, they have been spoken to about their loyalty to the organisation. They have been challenged that they are going to make the agency liable to be sued, to be prosecuted. And it has been a really difficult time for social workers and other people who are trying to flag. One of the interesting things when we set up our safeguarding group was the first presentations that we were asked to give was about how can we, how are social workers protected for whistleblowing? And one of the things I'd say is that, you know, we have a huge amount of protections. We have a huge amount of legislation for whistleblowing, for employment legislation. We have no legislation for protecting and safeguarding adults. Despite all of that, I'm very positive about the fact that we are having these conversations more and more. Our structure in the Republic is so disjointed that if we can get an opportunity to create a sustainable and independent authority, we really need to grab it. We have seen in COVID that things can change rapidly. That's things that can take years can be done in a couple of weeks, in a couple of months. We have that universal message to get out that safeguarding is everyone's responsibility and people need to report it. We need the governance and management structures to really promote and protect residents and support staff in that raising concerns and raising issues up higher so they can be resolved. I know a lot of social workers don't like to see safeguarding as a specialist role, but I think really it is. We are the only profession that's, as a discipline, is trained in the human rights focus. And that's one of the great knowledges as well that we have, is about how people abuse, complexity, how an abuser grooms a system, not just individuals. They groom the systems. They learn how a system works so that they can find ways to get around to abuse people, to disempower their victim, to make sure their voice isn't heard, and to silence. And silence is a really big thing with older persons and elder abuse. We need to break that silence. regulation. HICWA, as we said, they've talked about a 71% increase in concerns by private nursing homes to their service last year. They're looking for an urgent review of their powers. And one of the things that I really would welcome as well is that the safeguarding teams, there's been no review of us. I really think that there should be more regulation of us, that somebody should be looking at how we are providing the service. Are we providing it equally across to all of our services? Interagency collaboration, Bernie mentioned GDPR, and I know we've had lots of discussions about, I could go to the guards in one part of the country, they would share information with me, in another part they wouldn't. What I will want to mention also is the courts and legislation. You know, we are really seeing the high courts in particular as my favorite lunacy act, but they are really pushing now. And when we've been in court, been really impressed with the judges, how they're thinking, how they are bringing in the assisted decision-making thinking into their judgments. They're increasingly asking for the voice of the person to be heard. They're appointing guardian ad litems or social workers to them, or the judges themselves have started to meet with the person who's subject of the wardship so that they can hear their story and they can include them in as much decisions. I've mentioned again thresholds, and you know, I really think as a society we need to keep that zero tolerance approach, because we're not mature enough. We make too many excuses for abuse. And again, I mentioned social work and the human rights approaches. You know, Joe said earlier about the restrictive practices, and you know, I think social work has been a huge advocate in that and challenging the restrictive practices. We've had very, you know, distressing things where people's wheelchairs are left too far away from them, their walking aids are left too far away from them as a punishment, because when you got up the last time and you fell, and I had to fill an incident report form. But you know, if somebody wants to get up and walk and take the opportunity and have a fall, that needs to be recorded. It needs to be, this is their right to do it. The power of doing nothing. Sometimes the social workers and safeguarding, we work very hard to make sure that other people's good care plans that's in somebody's best interest don't happen, because it's just as Mumby said, what good is it making somebody safe if it merely makes them more miserable? The one thing I'm going to say is we have a lot of things in progress, and on my sheet I did mention that the Department of Health have their safeguarding committee group at the moment. The two voices absent from that are social work and service user groups. And I think these are the voices that needed to be added to those committees, who are working really hard, and we're really looking forward to the publication of their national policy, because it is something that needs to be a national focus. We're not going to be able to do this just as social workers or as families. We do need that national collaborative effort. So no more than Children First is now across all the departments. I think adult safeguarding needs to have a place across all departments too. My final thoughts, because I know I have gone way over my time, because I always do. And I think this quote, it goes for all of us, you know, as family, as a HCA, as a social worker, as a policymaker, as a manager. You know, may you never be the reason why somebody who loved to sing doesn't anymore, or why someone who dressed so uniquely now wears plain clothes, or why someone who always spoke excitedly about their dream is now silent about them. May you never be the reason somebody gave up a part of themselves because you were so demotivating, non-appreciative, hypercritical, or even worse, sarcastic about it. Now is an opportunity for us to really focus on getting this right. We have heard all of the stories, we know it all. We now need to have our action plan in place and to work together to safeguard older people.
Thank you, Celine. That has been another very intriguing presentation, very thought-provoking, very emotive, and has certainly brought up a lot of comments and questions from folk. And it has, the whole overall seminar has just raised so many different perspectives about these major issues. And I think most people are left with a lot of questions, not all which will be answered now, but we have a little bit of time for questions and answers. So Celine, thank you so much for your part in that and for that presentation. I really love that last quote that you've just put up there. and we'll be keen to get a little copy of that one to make sure that we can use it, because I think it says everything. May you never be the reason why somebody basically isn't themselves anymore, is the essence of that. And I think that's what this has all been about. So there certainly will be thanks at the end for the entire panel, because we appreciate every single one who has taken part and every single comment that has been made, and the time that has gone into the preparation and the heart that has gone into that from each of you. Really appreciate that. So thank you. For now, I think there is still time for a few questions and answers to be fielded. There's too many to ask them all individually, but there's one key theme that's coming through here, and it really reflects the complexity of what we're talking about, which is the almost balancing act that needs to be done whenever we are looking at how to get this right, because I think the end result of today is about what we can do, what action can be taken. It's not just about talking, it's about what can come next. But there are questions there about balancing the need to put protections in place without it becoming such an administrative process that it's no longer effective, without overlooking the rights of whether it's an older person in a residential home or any other person, for example, as was discussed earlier with learning disability in homes, without overlooking their choice, capacity, ability to say, no, we don't want this, or to look at who's maybe where there's coercion behind the scenes. So there's quite a few comments there that are about where is the balancing act, and I'm going to leave it open to ask which of you would like to respond to that. Not an easy question, but it's the balance between putting the safeguards in place and equally respecting what is needed from the rights-based perspective, and equally managing that in a way that it can actually make a difference.
I might go start with that, because I think that's what we do on a daily basis in social work. Is we tolerate a lot of uncertainty, we manage it and hold a lot of risks that other disciplines, other services wouldn't. And I think that's the key pieces about that relationship, that you spent time with the person, you know what their will and preference is, you get a full sense of them. I remember as a student social worker, just even talking to a lady in her family, and this is a lady who she'd been signed off for long-term care, she'd a broken hip, she was 93 years of age. I spoke with her and her family. She was a champion Irish dancer, the first time that they held a fesh. I remember presenting that at the multi-team meeting, and everybody's head came up and went, what? And I said, she's got the trophy for the first ever Irish dancing competition. She all of a sudden went from being, channeled straight to a nursing home to 6 weeks of rehab. She walked out, she went home to her family. And that's the difference, that relationship. And it's not that the people in that multidisciplinary team didn't care, but they didn't have the time to sit down and get the story, to have the relationship. Time is so important, and that's what we need, just to let people tell their stories. It's their life. Yeah.
Thank you. That's a really good illustration of exactly that point, and bringing back the person. And you've touched on another comment that has come up in several different ways, which is about the staffing levels, the time. You've just mentioned that about the time. It's not that people don't care, but whenever there are so many things to be done in a day, it was said earlier on as well, very few people leave their house in the morning or show up in their workplaces, whatever that form is these days. Very few show up and want to do harm. They're coming in to do the best they possibly can. For the most part, there are exceptions, we know. And that pressure, the staff pressure and inexperience and training and coming into a culture. So again, I'll leave this open in terms of who would like to respond to that, about what can be done to change that crisis, which is about overall staffing levels and time. Eddie?
Yeah, I think the conversation that we're not having at the top level of government, and it's something that I've been pressing in our programme for government, is that the needs of our aging population should be higher up the political agenda, given that it's one of the biggest transformations our society is seeing. And I think, we go from one episode of a failing or a scandal or something, and it gets talked about for a while. But I think what's missing is the conversation about, you know, the type of health service we want, the type of care we want in place as a society, and then the cost of care, the true cost of good care, and what it requires in terms of investment, in terms of, you know, staffing. And I think some of the problems, certainly the problems I've found in terms of care homes, have been homes that have been under pressure in terms of staffing levels, turnover of staff, agency working, all of those things. I mean, that it's the time that Celine mentioned, the time for people to build relationships with residents is so important as well. And that's what you lose if you're constantly just have a different person coming in every day. And I think care, it's very difficult to keep care standards up high in that sort of environment. But I think we do need to have this conversation in society about what we want and how much it costs. And then I think most people are reasonable to have that conversation about, you know, how we go about then paying, investing in our health service to meet the needs of our population. And I just feel that my frustration is that it's quite difficult to get that at the highest possible level. It's not an issue that, you know, wins votes at elections. It's an issue that sometimes I think is in the too difficult to do box. But I think it's an issue that the more we kick it down the line, the more the problem's going to be. We should be having those conversations about how many, you know, nurses, how many social workers are we going to need to meet the needs of our aging population. And I don't hear that much being talked about. And I just think there needs to be that higher emphasis. And this goes across, I think, you know, most countries that are experiencing the same change.
Thank you, Eddie. There's a couple of comments I want to read in response to that. Thank you. That's very helpful. Before I read them, does anybody else want to add to that? That's been a really good perspective. Celine,
I mean, one of the things I think we should always be doing is working out how will we not need an abuse service. You know, if we put in all the preventative pieces, if we really invest in good quality training and staff. And for me, it's that piece of teaching staff to speak up. If there is a problem, don't be afraid. You need to say it. We're going to get better. We need to improve all the time. And not as staff saying, if I say this, nobody's going to have a cup of coffee with me. I won't be invited to the christenings or the weddings or the team developments. I'll be kicked off the WhatsApp group. And these are the small little personal things that, you know, people have to be brave. But you also shouldn't have to be brave. It should just be what we do.
Thank you for that, Celine, and it's so right. I'm just going to read a little comment here from Mo that says, I feel that if the government paid reasonable rates for the patients or residents stay in care homes would be able to pay a good wage to staff so they feel valued, have adequate staff and supervisors, and be able to offer more meaningful activities. And then she says, what do you think? I'll respond to that in the sense that has also hit a chord. It would be way over 30 years ago. I worked in residential with adults with learning disability at the time. And one of the most precious memories I will carry with me forever would have been late at night or early in the morning with one little tiny lady, and she was tiny, who had very severe diabetes, and her little toes were all curled up. And what was really essential every single day were that her toes were washed, cleaned. And I will never forget what it felt like to be able to be on my knees with a little basin and her little smiling face looking down at me as I washed her feet. It's one of, in all this social work life that I've been in, I think it's one of the most precious memories I'll hold. And I also know that if I went to some of those similar places today, I wouldn't have the amount of time that it took to do that. And that would be simply heartbreaking. So there are really, really heartbreaking issues to be dealt with, but a lot of it comes out in what Mo said there. There was another comment I'd like to read out. If I can find this one from, again, just reinforcing from Annette, I do think there needs to be stronger emphasis on safeguarding in the training programme for medical, nursing, health and social care staff. They do not understand and or recognise that neglect or even a pattern of safety incidents can be a serious safeguarding issue. I mean, there are just so many comments on the same lines. Some homes in the south cost €1,400 per week per person. How can this not be sufficient to provide a good quality service per individual? So there's a question for anyone in that environment that makes it sound like there's a lot of money poured at it and yet it's not good enough care. Any thoughts?
Yeah, I can chip in there. The
Thank you.
Connor's unit was £3,600 a week. The food was shit. Obviously, there was no care, and yet the commissioners pay that amount. And I do know 2 young people whose care package in an ATU costs £11,600 a week, and it's appalling. And you just sort of think you could just go and stay in the Ritz penthouse, order room service, have a massive telly on the wall, and you would probably have much better service and better bang for your buck than you would chucking those amounts of money down the drain. And I hold the commissioners responsible for that because they keep doshing it out. So
thank you, Sarah. And again, that obviously comes from very personal experience of money does not translate. There's a comment as well from Clina about this, asking could the panel comment on the privatisation of care and the for-profit model we seem to be rapidly moving towards, which is relevant to this discussion, with massive foreign investment in our nursing home sector?
Yeah, so we have seen that in the last year, we've seen lots of our nursing homes being sold. I think it was a Chinese conglomerate and a French conglomerate, and there's massive money involved. But we're also seeing it coming now into our home care. So some of our home care private agencies have also been bought out by French companies. It's not getting any comment from the newspapers or journalists, but it isn't a really interesting thing, because then it becomes about who's in the bed. We need to have somebody in the bed. One of the concerns we would have had during COVID is a lot of people were moved to nursing home to make places in the hospital, but the plan was for them to go home. But who's doing that? It's now a year later. Have they still got the skills and ability to go home? Will a nursing home say, actually, we need to flag this person with you because we think they could go home? Or are they going to say, well, actually, we need to keep them here because that's our profit margin? So, it's whose interest are people working, are human rights at the forefront of the state's mind, at these private agencies' minds. Yeah.
I would like to make a comment on that. I think the mixed economy of care is an important element of social care provision. I don't think the argument is between whether or not the statutory sector provide these terrible homes or whether the private sector provide these terrible homes. The issue is the model of care, and that's a policy issue, and that's with our government and our both North and South. They need to have a policy issue on this, because, and then as Sarah, I agree with Sarah, then it's about a commissioning. How do you commission services to meet the needs of your population? So investment is important, and investment coming in to the older people's sector is really important. But it's how that money is used, and how that money is used should be determined by the policy. So if you get the policy right about what the model should be, then the government should have control over how these services are provided, not the other way around. Not big business coming in and saying, well, we can build a 300-bedded unit and we can fill it full of people and we get loads of money out of it. That should not be allowed. If you look at the children's sector, the policy is about reducing the size of the children's homes down to no more than 6 children in a children's home. Now that hasn't been fulfilled, that policy direction, but that's what the policy says. So we should be looking at policies that say that care should be person-centered, that there should be individual. And Professor Ryan's right. There's millions of pounds being spent on these services, and all they are, in many cases, is holding arrangements. So the more people you can put in, and that is not for the provider to decide. That should be a government decision, and a policy should be around person-centered care.
Thank you.
It doesn't really matter. It doesn't really matter what the mixed economy of care, whether it's the voluntary sector providing it, the statutory sector, or the private sector. That should be controlled then as to what they're actually providing, rather than the other way about.
Thank you. I'm just going to read out the comment. I'm not sure if it's quite yourself. I think it is. You put in the chat, but it's not to everyone, about looking at domiciliary care in Northern Ireland as well. That the services, because that's equally behind closed doors for a lot of people, which is why it's so relevant. It's not only residential. About the commissioning and blocks of times that are unrealistic, leading to staff having slots as low as 15 minutes to provide an effective and personal service to the individual. And it also means that most domiciliary care agency workers are paid per visit and not for the travelling time between. So for too many of those staff, it's financially unviable to stay in that work. I mean, incredibly important stuff. I'm very aware of the time. There's one question I just want to touch on because we haven't explicitly addressed it yet, and it'll only take a couple of minutes to get some feedback. And it's about the safeguarding responsibilities and investigation cross-border situation when some authorities are making placements across the Irish border. So it's, you know, that can apply several ways in the way we live. But what's important about that today is we have representatives here from obviously the Irish Association of Social Work, who has put this whole thing on and worked with us in British Association of Social Work. So any comments about that cross-border complexity that we also have from anyone?
Well, that has also been made very much more difficult, Michelle, because of Brexit.
Yeah.
And there's an issue about, for example, social work regulation, other regulation of people. But we are border counties. We have border counties. We have people who live one minute from the border. So we will have that cross border all the time. And it's been made much more difficult by Brexit, but that's just really a comment I want to make.
Thank you. And Celine, do you want to add anything final there? And
yeah,
then
I was just going to mention the Brexit word as well. I think, but again, it's communication. We have to get our communication pathways right.
Yeah, thank you. I really do want to just thank everyone so much for your time, and I will give you all your thanks. The messages that I think have come through really clearly from this have been, certainly it's about justice for all behind closed doors, wherever those doors are in whatever setting. Appreciate there's a lot of comments we haven't got to. I think there will be some follow-up opportunities afterwards. Just get in touch with the organisers. I'll allow Sarah to come in at the very end for that. But certainly from the social work profession, dignity, respect, rights, culture, compassion, all those words that are not words to each of us who work in this area, they are real meaning. And to me, the sense of being human and being human together, but not stopping there, being human together and taking responsibility is what I've heard from everyone today. And on behalf of everyone who's organised this, we want to say thank you so much to everyone. I want to start with Sarah, who's just showing her face there, because I know everyone would like to say thank you to Sarah, because Sarah has put so much time and energy and effort behind the scenes for so long with this one. So thank you so much for that, Sarah. We've had co-chair Vivian, so thank you, Vivian, as well, for taking part in that and doing this and sharing the load for this part of it. For Professor Joseph Ibrahim, who's had to leave us but has left his email address. For Sarah, who spoke very well, with Susan, of course, and her very, very personal input, which I think will stay with everyone. For Bernadette McNally, thank you, Bernie. Thank you so much for everything that you have chipped in there and taken part with in preparation. For Sarah Ryan, again, incredibly personal experience, along with a very professional perspective on that, and something that everyone will carry with us. For Eddie Lynch, it's really good. I appreciate the amount of time as well that you've taken out, and it's really important to see a presence like yourself in the middle of a webinar like this, so thank you for that. For Celine, thank you so much for your presentation as well, and for the very real heart of social work perspective on that, which was lovely. And all we can say is thank you. There's one note, Sarah, to answer about slides. There's been one question if there's slides available afterwards, but I will hand that back to you. And thank you very much.
Thank you, Michelle. And before I forget, I'd like to sincerely thank you and Vivian for doing a fantastic job in chairing both the first session and this afternoon session. You've really helped to weave everything together. And again, to thank all of our speakers again for giving so freely of your time. It's really been such a fantastic event and really important to mark, I think, World Elder Abuse Awareness Day, particularly given the context that we're in. And again, I'd particularly like to thank Sarah Ryan for giving us that different perspective in terms of younger people and I suppose abuse and care settings as well. So yes, we can make presentations available if people would like the slides. Just email me, and we're hoping we can make the recording available. I know the sound was a little bit iffy at times, but we'll do our best to edit it and make that available for people who couldn't attend. So on that note, I'll just thank everyone again, and safe home and enjoy the rest of your day. Thank you.